Okay. All right. Good afternoon, everyone from Singapore. It must be in the morning for Europe, and or is it afternoon? Oh, Europe is in the morning, and then the Americans are just waking up. So today's program will be dealing with primarily pleural disease, as well as pushing the envelope of what we can do with interventional pulmonology. So pleural disease is very, very close to my heart, and also thoracoscopy. And we have Professor Marios Froudarakis, who's from the medical school at the Democritus University of Thrace, Alexandroupolis, and he is currently working at the Centre Hospitalier du Florence in France. So he has kindly agreed to give us a historical perspective of thoracoscopy from its inception by Jacobaeus in 1910. So it's been close to 120 over years since its inception. So without further ado, I would like to invite Professor Froudarakis to give us the evolution talk.
Thank you, Pyng, and thank you for the kind invitation. It's a real honor and pleasure to me to be among you at the WABIP webinar today, dedicated to those great guys, Ikeda and Hans Christian Jacobaeus. Well, my talk is based. It's based on people and what they do all over those more than 100 years now. It's a tribute to those people and the technique they have emerged during these years. And of course, I have no conflict to disclose in relation to this lecture. Well, this is the father of the technique, Hans Christian Jacobaeus, a Swedish internist physician who used first a cystoscope to get into the pleural space in patients with tuberculous pleural effusion in the early 90s, and he was the first who published about the technique in pleural disease, noting that this method has a vast potential. And his publications were based mainly in how to cut the adhesions in patients with tuberculous pleural effusion to perform pneumothorax in order to heal those patients. This is well known as the Jacobaeus operation. However, he's also the father of diagnostic thoracoscopy, as by doing the technique, he was able to distinguish with some certainty between the tumor metastases and tuberculous changes in the pleura. He was also the father of operative thoracoscopy by performing the Jacobaeus technique, cutting the adhesions to perform pneumothorax, and he was also able to inspect the whole pleural cavity and observe the solid intrathoracic tumors and their relations to the neighboring structures like lung, thoracic wall, so to guide the surgeons whether they can perform or not a surgical procedure. Since then, there were many publications in the early 20 to 50 involving the technique, and the technique was diffused all over Europe with great success and very low complication. The numbers haven't changed yet, although the devices have progress. And this is the first guy, Felice Cova from Milano, who has edited a book on thoracoscopy with atlas and describing the technique, and of course all the features that found in the Pleural. That was in 1928. There were in the 20s other books also interesting, especially the one from the Masson editions under the guidance of Professor Leon Bernard, the Mistal book, who was really innovating because it contained the whole description of the technique with the instrumentation, more than 400 pages. Then Anton Sattler, who was an Austrian physician from Vienna, described, was the first, in fact, to describe the possibility that a bleb was the reason of pneumothorax, although it wasn't ruptured or collapse. And this was he was able to do it by to perform this observation by thoracoscopy. And Norman Bethune from Canada worked on pleural disease. He was the first, and he squeezed talc in the pleural space in 2 ports of entry. He was a surgeon until he sees the talc coming out from the 2nd port of entry. Then, after the 50s, we have the spread of the technique, after the Second World War, of course, over the different countries of Europe and in the USA, like Brad Sverga in the Netherlands, of course, Christian Boutin and Robert Lodenkemper in France and Germany, respectively. And we really, all of us are children of those 2 guys, Christian Boutin in Marseille, who developed the technique, published a lot, and also organizes significant courses to spread the technique among pulmonologists. The same in Berlin by Robert Lodenkemper. They both have each one a book dedicated to the technique that we do all have in our libraries. And then the newer generation, Professor Philippe Astoul, who took over Christian Boutin, and Charles-Hugo Marquette, now in Nice, but before in Lille. They organized significant courses within the European Respiratory Society and have published a lot of papers on the technique. They are well known, of course, because they have they offer many fellowships in their departments to educate young pulmonologists. Then we have many different schools over the Europe that I would like to cite. One is used to be in Belgium, in AZWB Hospital of Brussels with Professor Mark Noppen, who was well known because of his works on the pathophysiology of pneumothorax. he has shown that, in fact, the problem wasn't really the bleps or the bulla, but the pleural porosity. By squeezing fluorescein in the inhalation fluorescein and watching in the pleural cavity, he was able to see that the bleb didn't really capture the fluorescein, but the whole other surrounding the bleb pleura. Jean-Marie Chop and Martin Bruce, the two Swiss guys who, with their wonderful work on pleural empyema, and for Martin, and pneumothorax for Professor Jean-Marie Chop. He was also the first author and the coordinator of the first ERS guidelines on pneumothorax in 2015. Unfortunately, he died during the first wave of COVID by a bicycle accident. Then the Italian school with Dr. Marchetti, Gianfranco Tassi, Valentina Pinelli, and Professor Gasparini. They have a lot of work, organizes a lot of courses on in Italy, spread the technique all over the country and in Europe, and especially they work on mini microthoracoscopy with some number of publications. Then, of course, Paco, Professor Francisco Panadero from Spain, who work a lot on the mechanism of pleural disease. Especially, he's shown that small particle size of talc generate the inflammation, the systemic inflammation, and have to be avoided. That helped a lot to move into the large particle size and restrain, in fact, the distribution of talc over the different countries. And we do have a single talc actually to provide pleural disease in our patients that has more than 30 microns of diameter. And those two guys from the Netherlands, Hugh Anima and Julius Janssen. Hugh has worked on the confocal laser electromicroscopy. He was able, and his team, to distinguish between the malignant cells to the normal cells of the pleura. And Julius Janssen worked on autofluorescence thoracoscopy, and he was also the coordinator of the first large trial on talc in malignant pleural effusion, published in the Lancet from the European group of physicians. The German school, some of you probably don't know, but this guy, Dr. Ralph Heine, is doing a lot of work in the education by organizing, since 30 years now in Halle, courses, and he's also an innovative physician because he uses the cytology imprints for diagnosis of pleural effusion, and he has designed his own set of thoracoscopy, single port set. This is probably now the only set available for pulmonologists. He is working in Halle. Zale. And of course, those two people, Professor Colt and Professor Pyng, who worked a lot on Flexirigid. Flexirigid thoracoscope has emerged in order to spread the technique among the pulmonologists because it looks very much like a fiber optic bronchoscopy, one, and two, overrides the objections of the thoracic surgeon, and it is really very helpful in this goal. And from the channel, we can use a lot of devices that are often used to other fiber optic endoscopes like NBI, for instance, and Professor Miyazawa from Japan and his team were able to use NBI through this scope to provide information in case of malignant pleural effusion to distinguish the non-specific pleuritis from the invasion of the pleural cavity by malignant cells. New device that it has not been developed further because of some significant limitations like the large diameter of the thoracoscope, the absence of channel, and the need for three-dimension glasses, and the cost, of course, is the thoracoscopy, the thoracoscope, the three-dimension thoracoscope, which looks, I had the opportunity to see it once in a stand. It looks much, it works, we work much better with this because we have a three-dimension view of the pleural cavity and we can inspect better the difficult regions like the costopleural angle, the diaphragmatic and pleural angle, but those limitations have limited his development. So, indeed, we moved from the devices of Jacobaeus to the recent rigid devices and the more recent Flexirigid device. And the technique has also improved over those years from Jacobaeus to us, actually. And we are all, of course, who are interested and performing the technique, the students of Jacobaeus. However, I believe that we are in a, in a gap actually, especially in Europe, because there are many places like Spain. I'm not sure that after the retirement of Professor Panadero, there is anyone who is still doing the technique. France, after the retirement of Philippe Astoul, I'm the only one physician. Maybe there are another one in Paris who performed thoracoscopy, and to do that, I had to resign from my post at the University of Saint-Étienne, was also chief of the department because I couldn't work related to the rigidity of the administration. And now where I'm in a district hospital, since a couple of years, I can get back and work with the technique. And I have also offered a couple of fellowships in people, one coming from Brighton and the second coming from Romania, who have spent a couple of weeks with me to be educated in the technique, which I couldn't do at the University Hospital of Saint-Étienne. And there are some others. I don't know what is happening in Sweden, I know that the technique is spread in Italy quite well, in Germany related to the courses. In Switzerland, the technique has almost stopped. The last one is Martin Bruce, and he's not doing anymore as frequently as before. But I'm going to give you the example of the United Kingdom, how the technique has been developed from the late 90s with 11 centers and 13 physicians who were performing at the time thoracoscopy, to the early 2000s, where 70 centers and 17 physicians were doing something like 10 to 30 thoracoscopies per year. And these are data that are reported by Barrows. And most importantly is that the technique has been developed in district hospitals like mine, though, where there was no thoracic surgeon. And of course, what is happening now is that there are more than 40 centers, about 49 centers. I believe that since there are some more, with at least 2 physicians per center, overall about 100, and only about 30% of those centers have access in thoracic surgery. So most of them have been developed in district hospital. And this is certainly related to those two guys, Naj and Nick, who have, by their work on pleural disease, developed the pleural units over the United Kingdom. And of course, the development of these units have helped a lot in spread the technique, because I believe that this technique, we need it if we do or want to move forward in our everyday practice and in our research protocols on pleural disease. So the biggest challenge and our future direction is, I believe, to continue to educate young pulmonologists on this technique by organizing courses, and this is possible. We, some years ago, performed a survey among those who have attended our ERS courses. 100 attendees have responded to our questions, and in most of the cases, those were beginners in the technique. And of course, we see that 1/3 of those who have returned the questionnaire were able, after the course, although they were beginners, to start directly thoracoscopy, and 27% more were change their practice in their pleural unit. So yes, we can help people. We can help in spreading the technique, to spread the technique by organizing courses. So I would like to finish, and I hope I'm on time. And thank you for the nice invitation, and thank you for attending this webinar course, and to thank all these good friends and many more that I was unable to, due to lack of time, to cite their names, because I know that they work a lot on the technique on the pleural disease. Thank you very much.
Thank you very much, Professor Froudarakis, for the very excellent talk on the evolution of thoracoscopy, plus all the interesting points that have been brought up, and it's quite important that we should continue to keep the spirit alive and to promote the procedure in wherever we are, whether we are in Asia, in Europe, or in America. Sadly, I think thoracoscopy, the pickup in America is not as good because of limitations in the equipment. Yeah. So thank you very much. I will then hand the chairmanship over to the next session, which is on watching the pleural space. And Naj, whether you want to start?
Yes, of course. Good morning, everybody. My name is Najib Rahman from Oxford. Pyng, before we move forward, there's a question in the Q&A actually for Marios.
Okay.
That's from Talat Kilic.
Okay.
Marios, would you mind
Right.
replying? I'll read the question. So Talat is asking, do you think thoracoscopy should be performed by pulmonologists or thoracic surgeons? Marios.
It's a good question. I believe that thoracoscopy should be performed by one who really knows the technique. I don't care if he's a thoracic surgeon or a pulmonologist. I have a lot of thoracic surgeons to my former department in Greece who came as fellows to learn a single port thoracoscopy. And we see actually more and more people switching to a single port thoracoscopy, whatever they do, and in the pleura. And so it's not a real question whether we are thoracic surgeons or pulmonologists.
I think the most important point is know where your limitations lie. And if it is just for the diagnosis and parietal pleural biopsies, I think a pulmonologist is well equipped to do such a procedure. But if we are doing more challenging and pushing the envelope, going into the visceral pleura and the lung resection, I think that area should be in the realm of the thoracic surgeons.
Yeah, but you know, over time, you have people like Christian Boutin, you, Pyng, and Henry Colt, who, and Viscom also from Denmark, who performed resection of the lung parenchyma. Of course, actually, with the techniques we have, they developed, the thoracic surgeons, pulmonologists have based their interest only in pleura. But you know, I probably didn't have enough time to cite all the techniques before we were, and I was doing also some resections of the lung parenchyma for diseases, but we stopped since it became very complicated. You need a surgical theater, and I'm doing this only in the endoscopy suite. So yeah, you're right.
Okay, thank you, Marios. I think we should probably move to the next sections. Marios, thank you for an excellent talk. Pyng, thank you for the introduction. If I could introduce my two co-chairs, so in fact, I'll let them introduce themselves. So Deirdre, go ahead.
Good afternoon or good morning, wherever anyone is in the world. My name is Deirdre Fitzgerald. I'm a respiratory consultant in Ireland at the moment after spending a number of years working for Gary Lee in Australia doing my research. So trying to set up pleural services in Ireland.
It's great to have you here, Deirdre. Thank you. And then Alice.
Hi, everybody. Good morning, good afternoon, good evening. I'm Rozman from Slovenia, and it's my great pleasure to co-chair this session with Najib and Deirdre. So we expect exciting 75 minutes exploring some most important and evolving aspects of pleural disease management. Unfortunately, I have to leave at 6 p.m. to head to the airport, but I know that the session will be in excellent hands with both of you. So I think we are ready to start with the first lecture, and I'd like once again to introduce Professor Najib Rahman, who is a director of the Oxford Respiratory Trial Units and a leading authority in pleural disease. Everybody knows him. His research and clinical work have significantly shaped international guidelines and practice, particularly in the areas of pleural infection and effusion management. So, Najib, please start with your first talk.
Of course. Well, thank you for the introduction. Very kind of you. And it's an honor to be invited by WABIP to give this seminar. And it's wonderful to see more than 150 people on the seminar as well. That's fantastic. So my first talk in 15 minutes is about ultrasound techniques and thoracoscopic techniques. These are my disclosures. None are particularly relevant to the talk I'm about to give. When I thought about approaching this topic, in 15 minutes, one simply cannot describe the varied techniques that can be used with ultrasound, with thoracoscopy, but it is worth, I think, zooming out and taking a bird's eye view of the area. So the core principle is that we are using thoracoscopy and ultrasound techniques in the diagnostic pathway. And I think it is worth then rehearsing the evidence base of the diagnostic pathway, new evidence that has come to light in the last 10 years, and then to come up with an optimal diagnostic approach, which might enable colleagues and clinicians to select which techniques they should train in, which technique to choose according to the patient in front of them, and provide a strong rationale for what we are doing. I think in interventional pulmonary medicine, we have often simply taken the next technique and said, we can do this, and perhaps not always created a strong evidence base to back it up. So I'm going to adopt a slightly different approach in this talk. So this is the 2010 BTS guideline, which will be familiar to most of you who are on the call. And this is related to how to investigate the unilateral pleural effusion. It's very complex. It's now out of date, but I think it's very illustrative of the education that all of us received in the last 25 years on the management of pleural disease. And the first thing that the BTS guideline 2010 suggested is that you should conduct a pleural aspiration, remove fluid, send it for cytology, protein LDH, gram stain, AFBs, and only then, if you have not come to a clear diagnosis, should you move forward to obtain a pleural tissue through various things. And in 2010, it suggested ultrasound biopsy, CT biopsy, closed biopsy, or thoracoscopy. So sort of everything was on the menu, but the main point I would like to make is that this is a very linear pathway. You start with the patient, you remove fluid first. In response to those fluid results, you then in certain patients decide to do a CT scan, but then also obtaining pleural tissue in a variety of formats. And the question is this linear pathway still fit for purpose according to the newest data that has been published? So let's look at some of that new evidence in the diagnosis of largely malignant pleural effusion, although a lot of this also applies to patients with TB pleuritis, which I'm sure we'll come to discuss in the questions at the end. And there are three areas that I think inform our practice, or should, which is evidence on the use of thoracic ultrasound, evidence on how good initial cytology is in diagnosis, and finally, what's the optimal method of image-guided biopsy and how does it compare to thoracoscopy? So let's start with thoracic ultrasound. Thoracic ultrasound is a fabulous technique. All of you, I'm sure, practice it regularly. If you look at my screen here at the top left, here's the diaphragm, and you can see a clear nodule on the surface of the diaphragm. Over here, you've got clear evidence of nasty-looking parietal pleural thickening and visceral thickening. And in this video down here, you can see parietal thickening, nodular diaphragm abnormality, and a large nodule within the costophrenic recess. For many years, we suspected that ultrasound provided information that would lead us to a diagnosis of malignant pleural disease, and indeed, we have now proven this. So these are the two main studies in this area. Top left is from my group, and bottom right is from colleagues in continental Europe. And both of them essentially did the same thing, which is to look at patients with undiagnosed effusion, conduct a thoracic ultrasound at the bedside, so just the sonographic features, and find out whether there were sonographic features associated with a final diagnosis of malignant pleural effusion. And in short, and again, I've split this up as our study and then the study done in Europe, you can see here that the overall sensitivity and specificity for thoracic ultrasound as a sonographic technique is in fact really good indeed, 79 and 100% sensitivity specificity. And I would point out that this outperforms the historical control, which was the Leung of CT scanning, the Leung study on CT scanning. So ultrasound, in the right hands at least, would appear to have a better diagnostic yield sonographically anyway for malignant pleural effusion. So the first point to make is that we should probably be using ultrasound in the assessment of all patients with pleural effusion, not just to guide interventions, but actually to triage them to more or less likely to have malignant pleural disease. And of course, it's a bedside test. There's no radiation. You can repeat it, and it does appear to outperform CT, at least in the hands of expert practitioners. So ultrasound clearly should be an important part of what we do. The second part then is the first aspiration. The old guidelines, most people would say, always do an aspiration first, send it for cytology. That's absolutely the first step that we should make. So let's critically address that particular question. Firstly, pleural fluid cytology, we are all taught that its sensitivity is approximately 60%. That's what we tell everybody, that's what we tell our trainees. However, if you break it down according to the final diagnosis, this is some wonderful work done by the Bristol group. They looked at nearly 1,000 cases and asked the question, according to the final malignant diagnosis, what is the cytology of a single sample? And yes, it is true that if you have ovarian cancer or lung adenocarcinoma, the sensitivity is 90 or 80%, so that's pretty good. However, if you've got, for example, squamous cell lung cancer or mesothelioma, the cytology sensitivity is incredibly poor. It's less than 20%. And for others, it's somewhere in the middle. This is also similar data from my own group. I think what this tells us is that we may be able to personalize our approach a little bit. If you have a woman presenting, for example, with multiple lesions in the ovary, ascites, and a large effusion, I guess our pretest probability for ovarian is quite high, and then maybe doing cytology in her is reasonable because you're quite likely to get the diagnosis. If, however, you have a patient with a past history of CLL, let's say, who now presents some years later with an effusion, then I would argue that a 40% sensitivity is probably not worth performing the cytology. So just in terms of cytological sensitivity, pleural effusion aspiration is not that good a test. But I think we've now taken this to the next level, and I'd like to thank Kevin Blythe and his group in Glasgow for coming up with this term of incomplete cytology. Now, what does that mean? We know cytology positive and negative, that's obvious. Incomplete cytology is a term that we now use, and it's explained in red at the bottom right here, that the cytology is positive. The histopathologist says there's definitely cancer cells, but molecular markers that allow oncological treatment for whatever the disease, breast or lung or ovarian, these are not complete. And what that means for the patient and for you as the interventional pulmonologist is that you have to go back in. You've got to take another biopsy, take further pleural fluid. And if you think about it, our job is simply not to say the patient has cancer or not in the pleural space. It is to provide all required information in order for them to have full oncological treatment. And in this particular study, this was the diaphragm study, they took 238 patients, of which 63% were cytology negative in this particular multi-center study. And they looked very intelligently at what predicted cytology negative, as in false negative. And you can see that if the patient had asbestos exposure in their history or had a malignant looking CT, the likelihood overall in all comers of getting a cytology positive, the sensitivity was only 19% with an NPV of only 9%. So in the situation of this, which you would know before doing the aspiration, then the cytology in the NPV is extremely poor. And now if we look at the odds ratio for incomplete cytology, so remember that is cytology positive but inadequate molecular markers, we get some pretty shocking results. So I told you before that ovarian cancer has a 90% diagnostic sensitivity. That is true, but the odds ratio for incomplete cytology is 83. And that means that in most of our ovarian patients, we'll get the diagnosis, but we'll have to go back in. And I think this is really the completeness of cytology for molecular analysis is really where we should be aiming. My group has repeated this study in a different cohort. So Kevin Blythe's cohort, because he works in Glasgow, has a very high number of mesothelioma cases, and you might argue that that's not representative. We did it in a lower mesothelioma prevalence population, and we've looked at nearly 1,000 cases. A third of them were malignant. We found the same predictors of negative cytology: pleural thickening, pleural nodularity, male, and asbestos exposure. And then we asked one very simple question in this group of 1,000 patients: how often does the first cytology that you send result in the final diagnosis needing no further pleural intervention for diagnosis? And the answer is a shocking 32%. So in an unselected wide patient population, over 70%, 78%, 68%, sorry, of your patient population after the first cytology are going to need another form of biopsy or intervention. And I would argue that that means that in certain populations, we should not be doing the aspiration in a linear fashion. Let's move forward then to optimal biopsy method. So this is how we conduct image-guided ultrasound biopsy, and we use TrueCut is one particular company, but it doesn't matter. They're all the same pretty much. You move the needle in under real-time ultrasound control. You're aiming to cross the lesion. This has an open jaw technique where the jaw is pushed into the lesion, and then a spring-loaded mechanism that takes the biopsy as you go through. And this is my fellow, now a consultant in London, Anand Sundaralingam, who's conducting an image-guided biopsy. A few things to point out. This is a fully sterile technique. You have to have a nice inline technique, and you can see that he's lined up himself, the patient, and then the screen in a single shot. And by doing this, you can then get really good images and do an image-guided biopsy. And this is him doing the biopsy. So here you see pleural thickening, real-time technique, watching the tip of the needle all the time. You're crossing the pleura, and in this way you get tangential pleural biopsies. And we and others have shown that in the hands of pulmonologists who are well trained, the diagnostic yield of this technique is well above 80%. Here's another example. So this was a heavily septated effusion, possibly malignant, as you can see here. You can see the tip of the needle just here, and the jaws are opening between these two white dots. And then once we're in, we take a biopsy, and you can monitor for bleeding and other complications as well. So what's its role compared to CT-guided biopsy, for example? CT biopsy is very well established in the literature. Is it any good compared to CT-guided biopsy? Well, we can now answer that question. Thank you for this work done by Federico May and Martina Bonifazzi, who are two interventional pulmonologists who work in the north of Italy. And they did this systematic review and meta-analysis of the world literature in 2021, asking this exact question: ultrasound versus CT-guided biopsy. And this is their forest plots for the outcome. Now, I'd point out a couple of things. Firstly, overall, ultrasound-guided biopsy had a very good diagnostic yield, 84%. It would appear to be slightly higher in CT-guided biopsy, although this didn't reach statistical significance. But what I would point out is the number of cases reported in the literature. In the literature, CT biopsy is only reported for pleural disease in 410 patients, and ultrasound biopsy in over 1,500. So there is, in fact, a higher evidence base for ultrasound biopsy. I haven't shown you this data, but there was, in fact, a lower complication rate and what I would call a similar diagnostic yield. And I think this paper and others suggest that largely ultrasound should replace CT for pleural diagnostics within most circumstances. So that sounds great. Maybe we should all just throw away our thoracoscopes, use ultrasound for everything, off we go. But let's just step back just for a second. This piece of work done by Anand Sundaralingam, again in my unit, he was asking the question about molecular profiling from pleural biopsies, similar to incomplete cytology, but this time from biopsies. And we looked at 183 cases in my unit over a year and looked at the diagnostic method that achieved molecular profiling. And this is what he found. The only bit of this busy table I need you to look at is this box just here. So in here is the diagnostic molecular sensitivity of the technique. Thoracoscopy, 95%, CT biopsy, 86%, ultrasound biopsy, down at 77%. So it would appear that although ultrasound biopsy is a good technique, it is not as good as thoracoscopy in terms of achieving your final molecular diagnosis. Now, what about thoracoscopy? Well, we're all familiar with this technique. So I'm showing you a two-port biopsy technique on the left-hand side here, and on the right-hand side here is a single-port biopsy technique that Marios very elegantly talked about. How good is this technique, and what should we think about it in the current diagnostic paradigm? Well, this is the paper to read at the minute, and this is from David Ost's group, who's in MD Anderson. They did a wonderful meta-analysis of sensitivity and complications of thoracentesis and thoracoscopy. And what they showed is in an enormous number of cases. So if you look here, this is 41 studies, 5,600 patients. and the thoracoscopy had a diagnostic yield here of 93% overall, which is a wonderfully high diagnostic yield, completely better than any other technique. I would make the point, as Marius had already, whether you use rigid, semi-rigid, a combination, general anesthetic, local anesthetic, or a combination, the diagnostic yield is always high. So I think the technique doesn't matter. What matters is that it is available to you. Okay, so let's summarize the diagnostic landscape. Thoracoscopy diagnostic yield 93%, ultrasound biopsy and CT biopsy in the region of 84 to 90%, cytology about 50%. And then we look at sufficiency for molecular markers. Pleural fluid is hopeless. And then I've shown you this already. And this means that pleural aspiration is usually not helpful. It's worse with CT findings positive and asbestos exposure. And CT and ultrasound biopsy are high yield, but less for molecular. So how do you then choose your technique? Well, of course, it depends on local expertise and local availability, but let's just talk about case selection very briefly in terms of anatomy and radiological findings. So here's a wonderful example. This is likely to be malignant. It's a large effusion. The diaphragm's inverted. There's nodules, but there is no pleural thickening just here, and therefore ultrasound biopsy may not be helpful. This case, on the other hand, unless you're an expert thoracoscopist, you may not want to get in there with a thoracoscope because it's multiseptated. This one here with nice pleural thickening, you probably can do an ultrasound guided biopsy, whereas this one, it would be difficult to do an ultrasound biopsy because there is no clear target. And I'll just finally, Alice, before I finish, show two thoracoscopy videos. So this is a typical finding, as you will know, of large nodules in some places and then fairly bland looking elsewhere. That's why thoracoscopy is such a good technique. And then finally, this case was a lady with a massive effusion, and this was the only abnormality not seen on ultrasound or on CT. And for these sorts of cases, thoracoscopy absolutely is the right way forward. So I'm making the argument that some patients should go straight to biopsy, and this is my last slide. This patient presents then, so who should go for a biopsy? If they've got asbestos exposure and malignant looking CT, cytology is a useless test, they should go for a biopsy. If they've got a thoracic ultrasound abnormality, I would argue that you can get it and therefore they should go for an ultrasound biopsy. If they've got a high risk of low yield or incomplete cytology, and that's listed here, they should go for a biopsy directly, and the rest, which is not very many, should probably go ahead and have an aspiration. And this is reflected in the current BTS guidelines, which suggest that you should go for ultrasound biopsy if you can, and in certain cases, you should go for thoracoscopy directly. So I'll just summarize. Ultrasound is useful sonographically. You've got to be careful of your low cytology yield patients. Think about the molecular diagnostics, and there's a clear argument to straight to biopsy in some patients. I must thank all of my co-investigators and thank you for your attention.
Thank you very much, Najib, for this very comprehensive overview of diagnostic methods in the pleural space. At the moment, I think we don't have any open questions, so all participants, please send us questions in questions or chat. I just suggest maybe we should move to the next talk and maybe have a question and answer session at the end. If you agree,
yeah,
of course.
Of course, no problem at all. Of course, I absolutely agree. So it's me again, I'm afraid. So it's going to be more action from me. Let me just bring up my next talk. Here we go. Okay, so you can see my slides okay, Alice?
I see them, yes, perfectly.
Perfect, good, okay. So my next talk then is on pleural infection. And again, we have 15 minutes to run through this really very rapidly. So this will be a bit of a whistle-stop tour. These are my financial disclosures. What I thought I would cover this morning then is these four areas: getting the diagnosis right, the microbiology we're not going to mention in great detail, predicting outcome, and then, of course, invasive treatment. So diagnostics, you are all familiar with this magic figure of the pH of less than 7.2 and more than 7.2. Obviously, if it's frank pus, this is empyema, this needs treatment. If it's microbiology positive, this is what we now call pleural infection, this needs treatment. And it's the non-purulent micronegative where we use the pH in order to differentiate complex from simple. And complex, of course, requires drainage and simple does not. But this is the original data that leads us to that pH figure of 7.2. This is from Hefner meta-analysis that suggested that those with a lower pH than 7.2 had a complicated clinical course. But you can see that this is not 100% sensitive. Not only that, but pH measurement is not particularly reliable in some situations. Loculation, if you've less local anesthetic within the syringe and so on. And the only thing I wanted to mention about diagnostics then is that the new BTS guidelines, published just a couple of years ago now, have taken this into account. And rather than having a black and white 7.2, 7.2 cutoff, we now give you a traffic light system in this particular situation. So if your pH is less than 7.2, this is very high risk for complex parapneumonic effusion, and they continue to need to be treated. Greater than 7.4, this is very low risk for complex, and therefore you can leave them alone and give them antibiotics. And we've now created this intermediate group that is just here, 7.21, 7.39. And if they're intermediate, then we ask you to do a few other things. So look at the LDH. If it's greater than 900, then drain them, especially if they've got a large effusion, if it's loculated, and if you've got other radiological parameters. And we think this is going to shift us towards more interventional treatment in this middle group, some of whom were not getting treatment thus far. Okay, let's move to risk stratification then. It would be great, wouldn't it, to be able to predict which patients had a bad outcome in pleural infection. We do know that there's a 20% mortality at 1 year and an average hospital stay of 14 days. And Nick Maskell and I did this work some years ago now. We used 2 randomized trials where we had the outcome available to us. Did they die or did they need surgery after 1 year? And we looked at baseline clinical factors that might be able to predict which patients ended up with a bad outcome. And this is what we came up with a multivariate analysis called the RAPID score. And I'll just go through it very quickly. Having a higher urea, a higher age, non-purulent fluid, hospital-acquired disease, or a lower albumin, each of these were independently predictive of a poor clinical outcome, which in this particular study was death at 3 months. And that gives you a total score of 7, and that gives you 3 risk categories: low, medium, and high risk. And this is what it looks like in the data. So we derived the score on the MIST-1 data set, and then we retrospectively validated it on the MIST-2 data set. Remember, all prediction models need derivation and validation. Most people just stop at the derivation point, and that's incorrect statistically. So let's concentrate on the retrospective validation set. Low risk had a mortality of about 3% at 1 year. High risk had a mortality of about 50% at 1 year. So this looks extremely powerful in predicting which patients are going to have a bad outcome. But we needed to do another study because the numbers, as you can see by the steps here, were small in MIST-2, and we needed to do a prospective validation study. And I'm pleased to say that was conducted successfully by my colleague John Corcoran, published in the ERJ now 5 years ago, and this was called the pilot study. What did we do in this study? We took patients with pleural infection from 50 centers around the world, including the US, Australia, and across Europe. And we asked clinicians simply to measure the RAPID score at baseline and then tell us if they had died at 3 months and 12 months. And this is what we found. So here is low risk in red, again, 2 or 3%, medium risk, risk of about 20% of mortality, and high risk about 50% mortality. And these are the 95% confidence intervals that do not overlap. So this is a very powerful technique that appears to predict mortality very, very strongly. The key issue that we're now trying to answer is the so what question. So we can predict mortality at baseline. The question is, can you use that prediction to alter mortality by changing the aggression of treatment? And that is subject to a series of studies that we are currently undertaking. Okay, let's move to intrapleural treatment then. Why would we be interested in intrapleural treatment? Because we know that both at thoracic ultrasound here, and you can see bubbles of air injected in agitated saline, not moving between locules, and then the same patient at thoracoscopy, these fibrin strands are one of the challenges of pleural infection treatment. A single chest tube may not allow you to drain all of the purulent nasty material out, and therefore can we disrupt the septations using fibrinolytics and other intrapleural treatment? My colleague Nick Maskell did this completely definitive study, MIST-1, placebo versus streptokinase, 450 patients, the largest single study out there in the literature. Everybody expected it to be positive. Of course, it was a complete negative. No single outcome was altered by streptokinase versus saline And remember, this was a double-blind study. So for a number of reasons that I won't go into, we then went on to do the MIST-2 study, where we were looking at both a more modern fibrinolytic TPA in addition to DNAs, which was given in order to strip the biofilm and also reduce viscosity. And this was a double-dummy, double-blind, placebo-controlled study that we conducted in 11 UK centres, 210 patients with a radiographic outcome. Here is the primary outcome slide then, and just to explain, this was the change in the X-ray opacity measured digitally over a 7-day period. So this patient here, this dot on the 0 line, had no change in their X-ray. These patients got much worse. They doubled their pleural shadowing, whereas these patients had complete clearance of their X-ray. So down at the bottom is good. And I'll just point out a couple of things. Firstly, placebo, which is just saline, clears about 30% of your X-ray. TPA on its own, exactly the same as placebo. DNAs on its own, exactly the same. But if you put them together, then you double the drainage, and the majority of patients in the TPA DNAs group had complete drainage of their chest X-ray. And this was associated with positive secondary outcomes as well. So the number of patients being referred to surgery in the TPA DNAs group was reduced by 83%, and the time spent in hospital was reduced very significantly. So this stuff looks like it really works. Remember, this was a double-blind study, so nobody knew what treatment they had had in order to make other decisions, like when to send them home, for example. What did we do with the MIST-2 result? Well, should it be standard of care? I'm a bit in the middle about this. We've definitively shown it improves the chest X-ray, and we have good secondary outcomes improving, like surgery, for example. Where do we use it now? Well, where you've got no other treatment option available, either surgeons aren't available or the patient is too frail. While waiting for surgical intervention, I think, is reasonable. Is it preferable to surgical management? We'll come back and discuss that just right at the end. But remember, after MIST-2, we only had 52 patients in MIST-2 treated with TPA DNAs. We needed more clinical experience. And up to the next study I'm going to show you, this was the world experience of TPA DNA. So there's our study and then study from Australia and a few others. But in total, there were 627 patients from 9 series using the combination of TPA DNAs. All of them showed a pooled treatment success of 90%, improving X-ray and reducing length of stay. So we needed a bigger study, and my colleagues Jason Akulian and Ihab Badawi then did this excellent piece of work called retrolysis. What we did in retrolysis was we retrospectively looked at all patients treated with TPA and DNAs over an 8-year period and got nearly 2,000 cases. The overall treatment success was in fact 80%, not as high as we had thought, but it did let us calculate very accurately the bleeding risk at only 4%. And of all those bleeds, only a quarter, so 1.3%, required significant intervention. We could also use multivariate modelling to predict who was at risk of a bleeding event. And unsurprisingly, if you're on anticoagulation, had renal impairment, or had a high rapid score, you're at higher risk of bleeding. And just to remind you of the bleeds, this is all 76 bleeds in the retrolysis study. And you can see here that 16% were treated conservatively, 53% needed a blood transfusion, and it's only this 31% that needed either an additional chest tube or surgical exploration. So the overall major intervention requiring bleeding risk is in the region of 1%, as long as you're not on anticoagulation. Other groups have looked into some other areas of TPA DNase treatment. So there's a lot of work going on with dose finding. There's a lot of work going on with reducing the frequency of treatment to once daily, allowing it to dwell for a bit longer. And I think we can probably discuss that in the questions. I personally still use the MIST-2 regime because that's where the RCT data is. Alternatives to intrapleural enzyme therapy, this is very expensive, of course, are irrigation and medical thoracoscopy. Nick Maskell's group is the only one who has done a randomized trial of irrigation to date anyway. This was the PIT trial, relatively small, 35 patients, and they randomized patients to normal treatment without TPA DNase or 250 mils of normal saline giving 3 times a day. That's what they called irrigation. And they showed that in the irrigation group, there was far less surgery compared to the control group. So strong suggestion in a small study that this might work well. It is, of course, much less bleeding and possibly less expensive, but it's a small study and was unblinded. So a larger study is needed. And indeed, I'm aware that colleagues in Europe are actually about to complete a similar study. Now, as pulmonologists, what about thoracoscopy for pleural infection? This is a case of a malignant effusion here on the right-hand side. It happened to be heavily septated and infected, and this is me with a two-port technique starting to bring down the adhesions, and then we do a lavage and push in a large bore tube. So it has some initial obvious attractions. There is good quality retrospective data. So this is from the group in Switzerland, Brütsche, 127 patients stratified by ultrasound, all of them with pleural infection. And on the surface of it, it looks like a very good technique, 91% treatment success, 6% surgical rate. But when you look at the paper a little bit more carefully, you find that 50% of these patients required additional treatment and 5% required a further thoracoscopy or a chest tube. And of course, this is retrospective and therefore selection bias applies. But there is now a small randomized trial, and I just wanted to spend some time on Adnan Majid and Fayez Khair's paper. So this is a trial randomizing patients to early medical thoracoscopy or the MIS2 regime. And on the surface of it, what we found in this study, it's only 32 patients if you look here, is that the median length of stay appears to be shorter using thoracoscopy than with the MIS2 regime with a strong p-value just here. I'd point out that there was no other positive outcome. However, again, if you read the details of the paper, the authors counted the outcome from the point of the intervention, not the point of randomization. So actually these, if you include the time patients waited for their thoracoscopy, there was actually no statistical difference between these two. So there was a methodological flaw, but nonetheless, this does look in selected patients to be a reasonable thing to do. And so I think this shows us that it's feasible to recruit to a randomized medical thoracoscopy study, and the authors did very well in doing so, but it was underpowered, and we need now a larger definitive study to answer this question. Finally then, what about surgery, considered the gold standard ultimate treatment in pleural infection by most people? We do have two randomized trials. Both of them are very small, 20 patients, 70 patients, very historic, 1997 and 2006. Both of them appear to show a great advantage to VATS over the current medical standard of care, but there were major methodological issues. So no blinding, no objective decision-making criteria, very selected population. So average age in these two studies was 40 compared to about 70 in the MIST studies. And so therefore, all of us do not currently use this as first-line treatment. But there is a strong argument for potential early surgery now that our colleagues are using VATS, and I'll just make that argument for a second. This is a wonderful retrospective case series of 4,400 cases of pleural infection, all treated by VATS, a 14% conversion rate to open thoracotomy, none of us wants that, and a mortality rate of 2.8% in operated patients. And when Tao et al. Looked at the risk factors for conversion, then the risk factor, one of them was us as pulmonary. We were delaying referral and giving them late stage disease. If our surgical colleagues did the surgery within 4 weeks of symptom onset, there was better overall outcomes. And this is important. Each additional pre-op hospital day up to day 5 was associated with a 1.2 times increase in mortality. So if we're going to do surgery, we need to do it early to get the best benefit. And on that basis, my colleague Ihab Badawi then performed this study. That's the MIST-3 study. So what were we doing? We were randomizing in a feasibility study to, at the point of entry into hospital, VATS as early as possible, or tPA-DNA as early as possible, or standard care. And this was a feasibility study, but I'll just highlight a couple of important early outcomes. So how long did it take us to get them the intervention? As you might expect, intrapleural therapy was given within 1 day of randomization, whereas VATS took 2.5 days to get to because of operative time and so on and so forth. So there was a slight delay in getting into VATS. But if you look at the length of stay overall, the length of stay between the two groups was exactly the same. And I think that's an interesting observation. It took us 2 days to get to VATS, but the length of stay was still the same. If we look at patient-reported outcome measures at 2 months, this is on a 100mm pain scale, you could see that 2 months after the intervention, the lowest pain was seen in the intrapleural enzyme group, 4.9mm, and in VATS it was much higher, 22mm. So potentially VATS is a bit more painful 2 months afterwards. And if we looked at quality of life, again, the IET group had a better quality of life at 2 months compared to the surgical group. So length of stay, it would appear if you get surgery, you get out of hospital very quickly, but that may be at the cost of higher pain and of a lower quality of life. And all of this has led us to do this study. So this is the MIS4 study. We are now going to randomize to early VATS or TPA DNAs. It's a phase 3 RCT in the UK. We're aiming for 600 patients. Ihab Badawi is leading it, and I'm hopeful that we will start recruiting to this in the next few months. It will take us a couple of years at least, but we'll finally definitively answer, should you have VATS or should you have TPA DNAs? Alice, in the interest of time, I will probably not go through the BTS guideline. Is that okay? I'm probably up against my timing here, am I?
But I think it's important. Just go briefly through it.
Yeah. No problem. So this is the BTS guideline. It's a complex guideline, as you can see. So I'm going to zoom in on different bits so that you know exactly what we're doing. So this is the whole treatment guideline. Let's zoom up to the top here first. So the first thing we ask you to do is to calculate the rapid score because it works. And then normally we would suggest inserting a small bore chest tube. And remember, there are a few patients where a direct surgical referral can be made. So that's over here on the left-hand side. If they're clinically unstable or if they have solid pleural thickening, there's no point messing around as physicians. We should just send them to surgery. In everybody else, you put a chest tube in and review their progress after 48 hours. You then can divide them into good clinical progress, which is a combination of X-ray getting better, inflammatory markers getting better, or poor progress. But we ask you to review that at 48 hours. Now let's zoom into what you do in the presence of poor clinical progress. We would suggest a thoracic CT scan. The first question is, are they suitable for surgery? And if they are, then surgery is still considered the first line treatment for failing initial medical therapy. However, if they're not, then we say give TPA DNAs. If they're very high risk for bleeding or you don't have that, then give them intrapleural irrigation. And if you are then delaying surgery by more than 48 hours, you should go ahead and give them TPA and DNAs as well. And finally, right at the bottom here, the difficult to treat patients. They failed intrapleural therapy. They can't have surgery. We've given you 4 options. You can switch, of course, reconsider surgery, but then switch empirical antibiotic therapy, prolonged antibiotic therapy, non-intubated surgical options, rib resection under local anesthetic, and in a very few patients, indwelling pleural catheters. So I'm finished now. Let's just go through that very quickly. Rapid works for risk stratification. How exactly we should use it is not clear, but maybe so fairly soon. We've got good quality RCT and then retrospective data showing TPA DNAs works. We know who's going to bleed and how to use it more selectively. I think there's some case series and small RCT data on the use of medical thoracoscopy, but we need better data. And finally, early surgery probably is very good treatment, but what is its role compared to IET? Unclear, and we should have answered that in the next couple of years. Again, I must thank all of my collaborators and thank you for your kind attention.
Thank you very much. Really excellent and comprehensive presentation once again. For the matter of time, I will just move to the next topic, the third big topic in pleural diseases, malignant pleural effusion. And please, Dr. Deirdre Fitzgerald, start with your talk.
I will open it here. Can you see my slides okay?
I see it, but put it in the, yes, this is perfect.
Yep. Okay.
Yep.
So good afternoon. As I say, I'm honored to be presenting in this group. And I'm just going to fly through some updates on malignant pleural effusion. And we all know that malignant pleural effusion is extremely common. It's very common all across the world, affecting about 200,000 people in the UK and the US every year. We know that it's significantly debilitating and it causes disabling dyspnea, and I'll run through the importance of that in a moment. We also know that diagnosis, as Naj has comprehensively outlined, can be difficult because cytology sensitivity is very poor and it does often require multiple procedures. And management, as has been discussed, requires multiple considerations, can require multiple repeated procedures, and that can lead to prolonged hospitalizations for a cohort of patients who have a short remaining lifespan. So it's really important to take all those things into account. So just to start with, I thought I'd go through everything using a case that presented to us recently. And this is a very breathless patient. She's a 54-year-old woman. She had a past history of breast cancer, treated with a wide local excision and lymph node dissection about 2 years ago, and was very well from that point of view, but had presented with a 4-week history of slowly worsening breathlessness and cough. And when we did her chest X-ray, of course, you can see she's got a very large pleural effusion. On CT scan, we can see that that's causing significant mediastinal shift. It's causing compression of the lung. And importantly, it's causing stretch of the intercostal muscles and compression of the diaphragm. So just to look at breathlessness in malignant pleural effusion, we know now that breathlessness has an impact on survival, or an association with survival, from Eleanor Mishra's work. They looked at data from patients over 5 randomized control trials and looked at their baseline dyspnea scores. And what they found was that patients who had less dyspnea at presentation were more likely to survive longer than those who had worsening dyspnea. But understanding what causes dyspnea in malignant pleural effusion is something that's been under investigation since probably the early 70s. And the PLEASE study addressed this, looking at 150 patients and performing a range of assessments pre and post drainage. And what they found was, not very surprisingly, in overall breathlessness scores improved from before drainage to after drainage. But when we looked at vital signs, we found that there was no significant difference in their oxygen saturations, in heart rate, or in respiratory rate. When we look at the change in lung volume post-drainage, this has been looked at in a number of studies over the years. And all of these studies have found that despite draining a large volume of pleural fluid, up to 1.5, 1.8 litres, we didn't see that significant increase in lung volume measured as FVC. And generally, you achieve about a third of the increase in lung volume is about a third of the volume of fluid drained. So it's not just all about the compression of the lung. In addition, not all patients respond to drainage, and a lot of the work here is geared towards finding out who are those people who will respond to drainage so that we can treat them appropriately. We found in the study that about 27% of patients didn't reach the minimally clinically important difference in breathlessness scores. And we also found that you were 4 times more likely to respond if you had diaphragmatic dysfunction pre-drainage. So what we believe is that the reason, or a significant reason, why patients are breathless before drainage is that altered respiratory mechanics occur, and that contributes to the breathlessness. This is an ultrasound looking at the diaphragm. So this is your probe is up here below the liver. This is the diaphragm here. And when we see the diaphragm moving normally, it should move towards your probe because it moves down on inspiration. This is on sniff. So a sniff should move down. In this case, the diaphragm is moving up when the patient sniffs, giving us a negative deflection on this M-mode ultrasound. And this can be useful in determining diaphragmatic function pre-drainage. So we believe that this poor respiratory mechanics leads to increased neural respiratory drive, but you don't get the same ventilatory compensation because the diaphragm can't improve its function, and therefore you get a mismatch. Drainage of the effusion then removes the weight on the hemidiaphragm and restores the respiratory mechanics, leading to improvements in breathlessness. So we took this a step further with PLEASE 2, and we looked at the contralateral hemidiaphragm also. And we found that the ipsilateral hemidiaphragm with the effusion is significantly impaired pre-drainage. And when you drain the effusion, that movement measured as excursion and diaphragmatic shape and thickness, and it improved back to pretty much normal post-drainage in most cases. But we also found that the contralateral hemidiaphragm moved a lot more pre-drainage and was restored also to normal post-drainage. So it seems like that neural respiratory drive is causing increased activity on the contralateral hemidiaphragm, and it's trying to compensate for the breathlessness. This has also been looked at by Kevin Blythe's group, where they did 4D MRI, and they had similar findings looking at the diaphragm. They found that the diaphragmatic movement pre-drainage was much greater than post-drainage. So certainly we're learning a lot about the pathophysiology of breathlessness, and that it is likely the impact on the diaphragm and the intercostal muscles is a huge part of it. So in our case, we had our breathless patient, and she did need symptomatic management. In addition, based on Prof. Rahman's talk, we would have thought that she would have had a high diagnostic yield with a therapeutic aspirate because she did have the history of breast cancer, and that seemed like the most likely thing. But we do always bear in mind that sensitivity is poor, as has been discussed. We would generally say the highest yield, or the evidence would say that the highest yield is with 2 separate samples. A third sample is generally not of value. And usually once you're over 50 mils, that's probably adequate for looking for malignant cells, but you are unlikely to get moleculars from that. So I would always send more than 150 mils in a patient who I think is likely to be cytology positive, in order to see if we can get those molecular markers. I would also suggest bearing in mind that if you do have a chest drain in situ for a patient who you think has a malignant pleural effusion, we often see these tissue clumps, and it's good to know that they may not be a complete waste. If you send them for histological analysis, you may find some malignant cells. And Amber Lau looked at this in Perth and found that in 20 tissue clumps, they found 15 had malignant cells, and 3 of those were cytology negative. And in patients, this was seen in a very small study of patients having a medical thoracoscopy, they found malignant cells in 4 of patients who were cytology negative. So for those patients who aren't suitable for surgery and aren't suitable for biopsy, it can be useful to send those tissue clumps to the lab. We've discussed CT and malignant pleural effusion, and this, in our case, certainly would be done in parallel with our therapeutic aspirate that we were performing for her breathlessness. And what you look for is, as has been mentioned, the study by Liang et al. Looked at circumferential nodular mediastinal pleural thickening that measures more than 1 centimeter. It is useful to note that split or delayed phase scanning can give you more likelihood of seeing that pleural thickening. So you can see a little bit of pleural thickening in the first scan, which is pre-contrast. But if you do a delayed phase scan, you can have more chance of identifying a pleural thickening that would be amenable to a biopsy. And so in our center, we do split bolus scanning for all our CT scans now. We've talked about sonographic features that indicate malignancy. This is an effusion that demonstrates a swirl sign, which is indicative of an exudate. And we also can see that there's significant diaphragmatic thickening and nodular pleural thickening in this patient. So these would be suitable. Well, the second picture would be suitable certainly for an ultrasound guided biopsy. And we've looked at the data for this in the previous talk. But the next step, or perhaps in parallel, if fluid cytology is negative, you can perform a biopsy. We always make sure to warn our patients about that noise, because it can give them a fright and they might jump. But the Konrad Kogellenberg looked at this in 100 patients, and what they found was that performing a pleural biopsy gives you a dramatically increased sensitivity versus performing a repeat thoracentesis. And also just, I suppose, to be aware, in centers that don't have medical thoracoscopy or thoracic surgery, an ultrasound guided pleural biopsy, in this case, even in cases with no pleural thickening, did give you good sensitivity. And that would be particularly true, I think, in an area that has, if mesothelioma is common, we'd often get good results from that. Again, ultrasound guided biopsy has as good sensitivity compared to CT guided biopsy. It's not as good, but limits ionizing radiation. And we would usually go for ultrasound guided biopsy first in an amenable patient. The target study looked at whether PET-CT was useful prior to performing a pleural biopsy, and they randomized 59 patients to either usual care, which was going straight to biopsy, and 30 patients had a PET-CT before the biopsy, and they identified the correct diagnosis from the trial biopsy in similar proportion of patients in both arms. So it's not necessary to perform a PET-CT before your biopsy. What is interesting is we know from data from previously that from John Corcoran that draining the effusion doesn't actually improve your chances of finding pleural disease. But this study from Gary Lee's group is going to look at whether instilling air into the pleural space can improve our outcomes, because we do know that if we have a chest drain in and we drain an effusion, when air is used as the contrast medium, so the dark air here, particularly in case if there's trapped lung, gives us a good view of targets for biopsy. So they're going to, they've taken 40 patients who have a likely malignant effusion, who have an intercostal catheter already in situ and a CT done, and they're going to rescan them prone after installation of 500 mils of air. So that data is under analysis at the moment. And of course, I don't need to tell this group about medical thoracoscopy, LATs or VATs biopsies. The sensitivity is extremely high, and it does offer the opportunity to perform a definitive procedure at the same time as your biopsy. But I would just bear in mind that if your VATs is non-diagnostic and you perform a talc pleurodesis, for a very small percentage of patients where the diagnosis remains unclear, they will have a PET-avid pleural space for the long term, and it can complicate your diagnosis later on. This is a patient of mine who underwent a number of biopsies after this because his VATS was negative and he'd had a pleurodesis. So once we have our biopsy-proven malignancy, what next? Traditional management would say that we should can perform repeated thoracenteses. We can perform talc pleurodesis via an intercostal catheter, or we can perform medical thoracoscopy or VATS talc poudrage. And we used to say these were novel, but indwelling pleural catheters can't be considered novel anymore. They've been in use since the 1990s. And in the BTS guidelines in 2010, they were recommended only for those with short expected survival because there was a cost benefit, or those with trapped lung. And I would like to think that at this stage, we have enough data to say that they're more generalizable than that. So I'm going to take you on a whistle-stop tour through the data we have supporting indwelling pleural catheters. First of all, from the Time 2 trial, which is back in 2012, we know that IPC is good for improving dyspnea and is at least as good as intercostal catheter and talc. In terms of improving quality of life, we know from the Optimum study that, again, IPC is associated with improved quality of life, and there was no difference between it and intercostal catheter and talc. We know from the AMPLE-1 study that IPC is associated with a shorter time in hospital, at least for the initial period and overall. And this is, as I said, really important for patients who have a short remaining lifespan. And so the percentage of their remaining lifespan that they spent in hospital was less in the IPC group versus the pleurodesis group. We also know from Time 2 and AMPLE-1 that when you compare IPC to intercostal catheter and talc, you have a lower rate of reintervention. And a small retrospective study by Hunt et al. Looked at IPC versus VATS and found much lower reintervention rates with IPC. And IPC is associated with complications, but they're usually manageable. Infection occurs in less than 5% overall and is usually managed as an outpatient with oral antibiotics. I should have mentioned the AMPLE-4 study is underway as well, and that's looking at prophylactic Bactroban on IPCs to reduce the risk of pleural infection. And if someone does come in with an empyema and a loculated effusion, we have some evidence to suggest that we can manage that effusion with intrapleural TPA and DNAs via the IPC, which is particularly important as this is a frail group who may not be suitable for surgery. Symptomatic loculation can also occur. It affects about 10% and again can respond to intrapleural TPA. IPC doesn't require any interruption of systemic therapy. We know that there's data has shown us that there's no significant difference in infection rate in those receiving chemo versus those who don't. Whereas with VATS, after a VATS, chemotherapy is an independent risk factor for death at 90 days, so can be detrimental. And with IPC, we can tailor it to the individual. So if an individual prefers symptom control, they don't mind having the tube in situ, they can be drained on a symptom-guided regimen. But we also know that if there are some patients who want to prioritize pleurodesis and removal of the tube. And we know from the ASAP study and AMPLE-2 that daily drainage can improve your pleurodesis rates. We know from IPC Plus that installation of talc via an IPC is safe and feasible. The actual pleurodesis rates were lower than may have been expected in IPC Plus, and that might be because the drainage regimen was slightly limited, was 3 times per week. So we would suggest that the optimized IPC, or what we call the epitome protocol, is an idea. So this is a first-line IPC in all comers and talc and daily drainage if they're suitable. We applied this in 100 patients and we found that 47% were suitable for talc. And after talc slurry via the IPC and daily drainage for 2 weeks, 74% of those were suitable for or achieved pleurodesis at a median time of 20 days. Only 2 of the 100 patients who had an IPC as their first-line intervention required a re-intervention over the following 12 months. So the TACTIC study is taking this approach in a similar line, but with thoracoscopy, that's inserting an IPC at the time of thoracoscopy and discharging them on the same day if appropriate, depending on discharge criteria. And the results of this are hopefully going to be released in the near future. And lastly, the AMPLE-3 study has completed recruitment, and again, data analysis will be underway soon. And this is the first randomized trial to look at IPC versus VATS pleurodesis, with the primary endpoint is reintervention rate. So coming back to the BTS guidelines again, this is the updated guidelines, and you can see that IPC has taken what I would call its rightful place as a first-line option for both those with re-expandable lung and those with non-expandable lung. And there's optimizing the management is going to be the next step. In summary, breathlessness and malignant effusion is multifactorial. We're learning a lot about how it's caused, and identifying those who don't benefit from drainage is going to be really important. Diagnosis remains challenging, but novel information that we have about scans and cytology is going to improve our goals, and doing tests in parallel is probably the more appropriate approach. And patient-centered management is key, and I think we're getting more and more information on how patients want to be managed. And thank you. That's it.
Great, Deirdre, thank you. Wonderful and comprehensive presentation. Thank you so much. Now, Alice, you have to leave very soon, don't you? 7 minutes, I think. Is that correct? Alice is frozen. That's no problem at all. We have 2 more sections to do then. There's lots of questions in the Q&A. Thank you very much. Sorry, Alice, say that again. Yeah, I think the connection there is not fantastic. So we have lots of question and answer sessions, but we've also got some interactive cases that Deirdre has very kindly prepared. And now we have a further 20 minutes, 15 minutes before the time for the sponsor break occurs, and then the next session. I might suggest that we do one of the interactive cases first, and then we do some Q&A. Would that be okay, Deirdre?
Yeah, absolutely.
Okay, go ahead.
So I'll go to screen sharing.
And if I could invite both Pyng and Marios to comment on the interactive case as we go, that would be great.
Yes, of course, Naj.
Thank you. And Deirdre, I'll stop you as we go. You go ahead. Thank you.
Okay. So my animations. So this first case is an 83-year-old lady who presented with dyspnea ongoing for about 2 weeks and bendopnea, meaning breathlessness bending over, which we believe is a significant symptom. And she had recently been diagnosed with non-small cell lung cancer and presented with this right pleural effusion. She's due to start chemotherapy soon. She's apraxial, normal blood markers, so not really suggestive of infection. Do you want to go with what you would do first, Naj, or?
Yeah, so let me ask Marios then, or Pyng to comment here. So we've got an elderly lady with known diagnosis of liver metastases and now a significant effusion, which is doesn't appear to have a systemic inflammatory response. So Marios, Pyng, what would you do next here then?
So this is obviously a right-sided moderate size pleural effusion. I would evaluate it with an ultrasound to see exactly what we are dealing with. And since she has bendopnea, it might be affecting her quality of life and resulting in her hospitalization. So drainage might be a very good in consideration. Assuming that the non-small cell lung cancer has enough tissue for molecular characterization.
Yeah, I think that's an excellent summary, actually. So there's 2 questions out there. There's the symptomatic and then there's the diagnostic side. I think here presume that she's got M1 plus disease, don't we? Because she's got liver metastases. So establishing a pleural diagnostic here is not particularly helpful. It's not going to alter her management oncologically. But in terms of breathlessness and bendopnea, it certainly will. So I tend to agree. Marios, you agree?
I fully agree because we know the diagnosis of the patient, and we also know that she's metastatic. So indeed, is not going to affect the overall outcome and therapeutics of the disease. Well, I'm not sure that the age has anything to do with, but I would also consider the age of the patient, and his performance status before proceed to any other option.
Yeah. I mean, I assume the PS is reasonable because they're about to start chemotherapy, so it must be 2 at least, mustn't it? Yeah. You go ahead, Deirdre. Thanks.
I suppose the next question that I would ask in this scenario is what intervention you would do first, and I think you would discuss that with the patient. And would you ever consider going straight to a definitive procedure, as in an IPC?
So, well, Deirdre, I think you have to be sure that your definitive procedure, which I would list as IPC or talc pleurodesis, we don't know which is more applicable or what the patient choice is, or if there's trapped lung as yet. We'd need to make sure that this patient doesn't sit in the 15% of patients who don't benefit from drainage, because otherwise you end up doing a definitive procedure for no reason. So in this situation, I would do a large volume aspiration for therapeutic assessment. And make sure that, because large volume aspirations are really good intervention, isn't it? It's very easily delivered. It can be done as a day case, and then you are a week later in a much more confident position that I made her feel better, and now I need to do something definitive. I think sometimes if the diaphragm is flipped, or if you've got a lot of respiratory mechanical embarrassment, then I think you can probably assume you're going to make them feel better. But I think for the audience, you should be careful not to just sling in a chest drain or an IPC in every case on the assumption that it will make them feel better. It may well not.
Well, in this case, this patient was, I've shown her CT there just to show that there's a large volume pleural effusion. So she actually had an intercostal catheter inserted by one of the medical teams. And we can, I think, yeah, you can see what the outcome there was. So what we can see here is that the lung hasn't fully expanded, and it's a really nice air fluid level to clearly demonstrate that there is an element of trapped lung. And the ultrasound video shows really nice, I think, pathonomic hydropneumothorax. So you've got the juttery air coming into view above the effusion, and you have the little dots of air swimming around in the fluid. So
yeah,
I suppose in this case,
can I just comment? I mean, I think under your care or Marios or Pyng's care, this patient would have had an ultrasound first. And
Yes.
I think you can tell from the look of that lung that trapped lung was actually quite likely. There's a lot of visceral pleural thickening. There's some good evidence out there on use of M-mode to predict trapped lung. And I think that's a little unfortunate, isn't it? Because a chest drain here is the one thing that isn't going to be helpful, because you can't do a pleurodesis
exactly,
probably, yeah.
So this was just to highlight that this was her original CT, in which you can't really see the pleural thickening. And I just highlighted this because she had a CT with a delayed phase. This was a CTPA, the first one. So there's not a delayed phase contrast, whereas this is her portal venous phase from her CT abdomen. And I just thought it was interesting to show that you can clearly see that she does have pleural enhancement and a little bit of pleural thickening there. So the other thing that often happens, I think, when someone has trapped lung in a chest drain is that the non-pleural, maybe respiratory people think it's a pneumothorax that's been caused by the chest drain. And it's very important that they know to put it on an underwater seal and check for an air leak. And if there's no air leak, then you can safely remove the tube. And so the next step, when she became symptomatic again, when the fluid had reaccumulated, we put in an IPC with good symptomatic benefit.
Yeah.
Is that what everyone else would have done?
I mean, in my practice, absolutely. I assume she had some degree of symptomatic benefit from the chest drain insertion and the relief of the weight of the effusion on the diaphragm. Deirdre, that being the case, then I would have done an IPC. Yeah, I think that's your only therapeutic option. Well, let me be careful, actually. In patients who have an extremely limited survival, repeat aspiration is not unreasonable in trapped lung. Some patients do have a very measured in a few days or weeks, and then there's a debate, isn't there, about whether IPC or repeat aspiration is better. I don't think it matters. What matters is that you get the physiology right, as you've rightly pointed out.
I fully agree with you, Naj. This is probably the only case I would put an IPC in my practice, because it's between a definite solution with a pleurodesis related to a thoracoscopic procedure and an IPC in a patient with a good performance status, with even already a diagnosis, is probably preferable than an IPC in in the two countries I have practice. This is probably the option, but just in case of trap lung, that will be either repeated thoracentesis or an IPC placement. Yes.
Yeah.
And it is very important to point out, I believe, the use of chest ultrasound prior to any procedure, because then the gliding side is very important to predict what is going to happen. The observation of pleural thickening, and I would like to get back to the first chest X-ray. We could, we can see that there is pleural thickening. And also what we can see that there is no line of demoiselle, it is convex. And we can see several lines with a pleural effusion who is probably a little bit loculated. Then we could imagine that this lung is at least has some problems in the re-expansion. And
I mean, yeah, sorry, Maurice, there's certainly on the right hemithorax, there's certainly volume loss, isn't there? And in the presence of the significant effusion, you'd expect the trachea to be pushed over, which it is not. And that, again, it's not a definite, but it implies that there's going to be trapped lung there. I think that's what all pleural docs would have said in response to that X-ray, but clearly under general medicine, not you guys. So, yeah.
Absolutely. And so the chest US is very helpful in distinguishing and in predicting the trap lung. Yeah.
Thank you, Marius. Carry on, Deirdre.
Yeah. So will I move on to the next case?
Yeah, go ahead.
So this might be a bit controversial. This is a 59-year-old gentleman who presented with a 1-month history of dyspnea. He had decreased air entry in his left lower zone, normal inflammatory markers, but he was hyponatremic at the time of presentation. So I was a bit concerned about malignancy. Again, you can see on his chest X-ray, he has a moderate effusion. No shift, but I suppose you might not expect shift at that level of effusion. But when you look at his CT, he did have rounded atelectasis in his left lower lobe. So the first step was we did a large volume aspirate and sent him home. And his pleural effusion didn't have, so just mononuclear inflammatory cells, scant mesothelial cells and nothing else. We went on to perform a biopsy of the pleura under ultrasound guidance. And again, that didn't give us any answer, just some fibrosis with mild chronic inflammation, no evidence of malignancy. So he went for a VATS procedure in another hospital, because we don't have thoracics in our hospital. And they took what I was told afterwards were very deep biopsies. And the biopsies showed chronic inflammation only. But when they looked in, they were worried about malignancy. They could see that he had trapped lung at the time of the VATS. And so they inserted an IPC prior to the results of his histology. He subsequently came back to our hospital. He was dyspneic. This is about 3 weeks later. He had, as you can see, probably not been managing his IPC correctly in terms of dressings. And he had a high white cell count, a high CRP. He had an acute kidney injury. He was actually anemic. His hemoglobin was only 6.6 when he came in. So we obviously treated him, got him stabilized. And then his X-ray had shown reaccumulation of a loculated pleural effusion. And his CT scan, you can see, is quite complicated pleural effusion. He's got air bubbles throughout the loculated fluid. So I suppose, I don't know if you want to weigh in now and tell me what you would do next.
I mean, there's two questions here, aren't there, Deirdre? The first is, what's the diagnosis? And that's unclear at the minute. It looks like a chronic inflammatory, likely benign effusion, but we don't know that yet. With the rounded atelectasis and so on, that's where my money is. And you've done a VATS biopsy, so that's the highest value biopsy we have. But this is an infected IPC-related space now. The underlying diagnosis matters less than trying to sort out that he's sick now, isn't he, with an infected IPC. the guidelines on this, and there are two from the American societies, would suggest that you treat through the IPC, so to speak, so connected to an underwater seal, give him antibiotics, assuming that we've done some pleural diagnostics. So we've taken some pleural fluid out of the IPC, sent it for culture, including blood culture bottle. And then if the LDH and so on is consistent, then I would treat this for infected IPC and maybe give TPA DNAs through the tube, depending on how he responds to drainage. What do you think, Deirdre? What would you have done? Well,
The
maybe.
results
This
of
is what we did.
they are
Okay, well, no doubt about the diagnosis here then, okay.
no.
No.
Yeah, but there is also lung restriction, right? Atelectatic lung,
Yeah.
as we see. Yeah. So I mean, I would probably also add physiotherapy, which is very important in this case. I'm sorry to say that, but we forgot that we also need to re-expand the lung, you know.
Well, a trapped infected lung is a disaster situation, of course.
Yeah,
and
absolutely.
Deirdre, I'm sure you're about to get onto that, but that's a difficult situation to treat. You carry on though.
Well, it was difficult, and actually, when we first attached it to an underwater seal, we didn't get any output. I was able to get enough for a sample, and as you can see, it grew Pantoea agglomerans, which I haven't seen on pleural fluid before. It's a bacteria that apparently is often found on vegetated matter, if anyone's seen it. So what we did for him was we did give him TPA and DNAs through the IPC. And actually, I was very conservative based on the fact that the initial fluid sample that I took out from the IPC was quite bloody, and he had been anemic when he came in. So there was an element probably of hemothorax within it. So I only gave him 1 milligram as a starter dose of TPA, and we actually got a really good response, as you can see from the X-ray there. And on ultrasound, obviously there's still pleural thickening, but we were able to drain out most of the effusion. And once we gave the TPA DNAs, this is what came out in the chest drain bottle.
Yeah, no, I mean, I think very reasonable. And the problem here is that you've got an infected visceral and parietal layer, and as Marius has said, without the lung expansion, then complete closure of the space is going to be very, very challenging indeed, isn't it? But that's the best that you can do, I think, in that situation. The only the sort of the backup strategy here would be asking the surgeons to go in probably at thoracotomy and do a decortication or pack it with a muscle flap, but that's very large amounts of surgery. So I would treat exactly as you have done. Yeah.
Absolutely.
Sorry, go on.
No, you go ahead, Deirdre, that's fine.
Well, so we did go back to the cardiothoracic surgeons, and they were not inclined to go back into his pleural space, knowing that his lung, with the rounded atelectasis, even if you decorticate it, may not expand anyway. He's not the lowest risk patient. He's has obesity. He just wasn't very mobile. So I think conservative management was the preferred choice. So we'll be seeing him back in a week or two and seeing how he does. But yeah, I'm fascinated by the variety of bacteria that we find on these IPC-related infections.
Yeah, I think, well, it's been in for 12 months, and I guess you don't know what vegetable material he's been doing with and what, I suppose. So that is one of the issues, that the home stuff. But we've had some success, Deirdre, with long-term antibiotics and regular drainage in this situation. I think one should remember that the purpose then is not to sterilize the pleural space, because that's unachievable. It's to suppress the infections sufficient that they end up with a reasonable quality of life and the infection's not dominant. But I very rarely, usually the difficult situation here is a trapped malignant effusion which becomes infected with an IPC, and then you just have to kind of take them all the way to the end. Yeah. Interesting. Really good case. Thank you very much indeed. So in the interest of time, I think we should probably finish the session there, Deirdre, if you don't mind. I must thank you for your excellent talk, and Marius and Pyng for your excellent input. There are lots of questions in the chat, and we can answer them by typing. So Deirdre, if you wouldn't mind answering from the bottom, and I'll answer from the top, and we'll just kind of meet in the middle while we're on the break for the next 5 minutes. Is that okay?
Yep, that's great.
Brilliant. Marius, any final comments?
I I believe that it's absolutely necessary to have all the techniques available when we develop a pleural service in our department, because we run in an era where the treatment should be personalized, and it cannot be personalized otherwise, but by having the whole horizon of techniques, and of course interventions and diagnostic also pool to provide a better treatment to our patient.
No,
I
fully
think
agree with that.
this case illustrates the important point about just liberally putting in an IPC when the indication is not strong. I think following the VAT surgery and the diagnosis is not established. And of course, post-IPC care is very, very pivotal in assuring that they don't get infection. So I hope that when he's discharged from the hospital, at least some amount of post-IPC care is given to him, you know. Yeah, and then perhaps if the empyema is better, maybe we should consider taking out the IPC if it's not indicated anymore.
Yeah, completely agree with that. And yeah, I think especially if it's not a malignant indication, you've got to be careful about IPC use. And look, it's fine to put them in first, but when you get the diagnostics back in 2 weeks, it may be worth pulling it out, actually. Great. Pyng, I might suggest that the people who've put questions in the webinar put it in the Q&A so that Deirdre and I can answer it by typing, because I think you need to move on to the next session, don't you?
Okay, sure.
Great. Thanks very much, everybody. Thank you.
Thank you.
Thank you,
Thank you.
session 1 team. And now we have a 5-minute break. I ask your attention to this short video from one of our sponsors. No, there's no sound on this video. Thank you all. Now let's move to session 2, pushing the envelope with chairs Dr. Hervé Dutau and Professor Levent Dalar.
Thank you, Michael. Hervé?
Hi, Levent. Hi, everybody. Hi, Michael. So happy to be part of this great event with Levent. Sounds event with Levent. This session, and again, thank you, Pyng, for inviting me to this event. So I heard that Annie from Indonesia could not join us to chair. So, but I would say let's start.
Yes.
Let's start. So the first speaker will be Spasoje Popevic from Serbia. He's a good friend from a long time, and he's going to try to answer to this question: what can we do more with the rigid bronchoscope? And to be honest, I'm very eager to listen what we can do more with the rigid. So Spasoje, thank you if you are connected, and Levent, if you want to have...
Yes, I'm here. Thank you. Let's start with my screen sharing. Just a moment. Do you see my presentation?
Yes.
Yes,
Okay.
the presentation mode we need.
First of all, thank you so much for inviting me. It's a great honor and pleasure for me to speak here. And I will, in next few slides, I will try to, to just point out why rigid bronchoscopy is so important, that we all know, and why it's going to be even more important in the future. So actually, rigid bronchoscopy started as a revolution, not as an evolution. Actually, if we go with the story of Gustav Killian, I found out that things started...
Spasoje, sorry.
Yes.
Could you correct your screen sharing?
Yes. You don't see my screen?
Yes, but not full presentation.
Now you can see my screen, okay?
Yeah, but
it's not okay now.
In the presentation mode.
It's not in the presentation mode.
No.
Okay, let me try again. Sorry. I will stop share and put it in the full presentation mode. Maybe that will work.
Perfect.
Just a moment. It's sometimes hard to do that. Solve its problem. Sorry for this.
Maybe Michael has a solution, no? Because he's very strong
in these techniques, yes. But
no.
Just a moment. Maybe in this view. I for some reason I cannot put it in the presentation mode.
Right, so maybe don't do it. But
no, okay. Maybe we should continue with next presentation. With Michael, while I solve this. What do you think?
The thing is that I don't know if the next speaker is connected.
If the next speaker is ready, I'm so sorry, but sometimes I have problems with.
We could play Dr. Rainbow Lau's lecture.
Yes.
Pre-record video.
I think Tom is here.
Okay, Michael.
Tom is here.
Okay. Thomas also, but
yeah.
It's up to you.
When you are.
Hi, Tom. Nice to see you.
Good to see you.
And now, so Tom, please what can we do more with Airway Stents? And
Yes.
I'm also eager to know.
Yo.
All right, let's see. Share. Share. Share.
Not yet.
Is that good?
Maybe that means Spasoje should stop sharing. Maybe.
I did.
Okay.
I stopped sharing.
So I'm afraid that we can do more with Rigid and Airway Stents than we do now. Finally.
Yeah, absolutely, absolutely. I stopped sharing my my presentation.
But which is already good what we are doing now. But
Well, there is always a room for progress.
Perfect.
Yes,
Good,
we
good.
see Tom's.
Yeah.
Can you go into presentation mode, Tom?
That work?
No, okay.
Perfect. Okay. Please,
Right.
you can start, sir.
Okay, perfect. Thank you very much. And thank all of you for inviting me to do this. I really appreciate the opportunity, recognizing that there are certainly other experts in the world that do a great job with this topic as well. Hervé, you being certainly the most prominent in this group. I have a whole number of disclosures. Probably the most relevant one is the use of a Visionaire, which is a company I founded. It's a spin-off company, and it's now in the private world. I have a number of other conflicts related to the grant support of this project in the beginning, and I'm currently employed with Olympus and part-time at Cleveland Clinic. So every time I give this lecture or a version of it, I point to this particular paper. I see several of the authors here on the call, Nick, Hideo, and Hervé. This is a fantastic paper. It's a couple years old, but the prominent key features of the directionality of the things that are in here, I see Pyng, you edited this, is a fantastic paper, and I use it as a reference for anybody who sort of wants to get a good view of the world when it comes to advanced interventional pulmonology with airway stenting. I do also want to congratulate Dr. Chada in the last year, published some guidelines that are very helpful for us in the field, particularly around airway stenting. Although this paper was around malignant central airway obstruction, it did touch on other things. It covered the indications, particularly airway stenting as it improves quality of life and survival in some groups. It's been shown to liberate patients from mechanical ventilation. They highlighted the need for a patient shared decision, which I think is a fantastic addition. This was done in a PICO format. The modality choices seem to be that the literature is now pretty balanced, and that there doesn't seem to be a clear winner from a stent versus metal stent, a silicone stent versus metal stent argument, and it's probably more contextual, but on its merits, they're similar. There is a mention of the aftercare, which is recommended. There's generally weak evidence, but there have been some nice studies showing that there's a wide variety of what people do, but people do in fact do stent maintenance and airway hygiene. And in specific cases where there's high risk or complex anatomy and early reassessment with bronchoscopy, we usually do it 4 to 6 weeks is generally recommended. And of course, there's an idea that you should not stent when it's not going to be beneficial. Certainly staying away from very small sublobar stents in cases where medical therapy alone may be appropriate. So an excellent review, and I think it's worthy of review of this folks who are interested. Now, I put this slide up every opportunity. If you live long enough, all stents fail, and this is irrespective of malignant disease, if you're fortunate enough to survive, or complex benign disease, and these are just some of the horrible examples. I always point this one in the bottom middle is a T-tube that I was cleaning out of the bronch suite on Dr. Machuzek's very first day with us, and I was sort of apologetically telling him that we do these bronchs just to clean out stents when it became suddenly occluded, and I had to pull it out. It turned out it was full of dog hair. The patient had been sleeping in bed with her dogs with the cap open. Mucus plugging continues to be an issue. And then on the bottom right, one of the most tragic cases is a woman in whom we put a silicone stent across an airway that was occluded by lymphoma. And then she stalled and delayed her therapy for the purposes of harvesting eggs for future utility and died of a mucus plug, which you can clearly see here at the end of the stent. So, just to highlight stents, you can see top granulation at the top. You can see in the middle lack of fit. You can see migration where the stent is in the stomach on the left. And of course, metal fatigue. Stents fail in many different ways. And so this is prompting me and others to look at different ways of approaching this particular technology. Now, the complications are to be considered in early stage. The migration, secretion, retention, and infection are realistic. Bleeding, of course, it's listed in 30 days, but it can happen at any time if stent erosion can occur. Granulation is a very consistent feature of late stenting. Fracture and deformation, as I showed, metal fatigue can happen. Chronic infection, a little bit more common on silicone stents in my experience, but can happen in both for sure. Then tumor overgrowth or granulation overgrowth can happen at the ends of stents. The risk modifiers, different stent types have different varying amounts of complications depending on clinical situation. It's not very well described, but we all know it to be the case. Airway geometry contributes to this, as we know, and duration of the stents impact. A lot of patients with central airway obstruction have median survivals on the order of months, 30 to 45 to 60 days in a couple of trials that we've done. And so it's not considered a significant problem. However, the longer you live, the more likely you are to have a complication. And of course, prevention and management, learning how to properly size and place these things, having a reasonably good airway hygiene regimen, including surveillance bronchoscopy for modification. And really, I think what's most important here is a clear plan for revision or removal as necessary. So I think Dr. Saka wrote a paper not long ago about the ability to remove stents at periods of time and leave people stent free, which can actually happen in high frequencies. And so over the years, I sort of learned this technique from publications in the Japanese literature. And this course won a video award at the World Congress of Bronchology a few years ago in Mayo Clinic, where you can sew stents together in different configurations. And in my experience, I call them Frankenstents because I'm not a very good vascular surgeon for my sewing technique. But nevertheless, I tried to do different stent designs. I've incorporated different stent materials. So you can see here in the middle, this was a typical Novatech stent, and I sewed a hood attachment so that I could have a softer stent feel. And over on the right, I had a hood Y stent for which I attached a Novatech stent, so I got to have a stiffer feel down that left main stem. And you've made unusual angles and cuts to account for holes or sewing on extensions or just even occluding it. So there's lots of things you could do with stents after they come out of the package, and certainly there's been great experience with this. And this is, of course, Hervé's paper in his group looking at the use of custom bifurcated stents. So on the left, you can have what's appropriately a Y stent, but on the right side, because of geometry, it becomes essentially a T-tube stent. And they just reported a series of cases in which lung transplantations, a very small number of them, 8% required stents. They use modified stents, 3.5% or 14 of them. At 157 days, 57% were left in. There was no migration. There was some granulation, mucus occlusion, and stenosis, as is pretty common in the lung transplant populations. But 76% of the stents were removed at 45 days, and with 63% with no occurrence. I mean, there is still a chance that some recur. But again, this is idea that a stent here, modified in a very good way, used as a temporary tool to augment healing, is a very useful tool. So the concept is here, the idea and application of the technology is right, and the question is can we do it a little bit better? I would say that it's hard to improve on Hervé's sewing technique, but we did our best. So the idea of 3D printing entered the fray. This is just a proof of concept paper by my friend George Chen using an off-the-shelf software tool where airway segmentation can be used to generate a 3D map. And then from that map can be turned into a CAD drawing and 3D printed, which of course led to future developments. This was our first in human experience. We had 2 patients, both of them with Wegener's granulomatosis or granulomatosis with polyangiitis, in whom we were using very complex stenting, including this Franken-stent here with sewn-on sections. The patient, despite multiple stenting, multiple configurations, had recurrent granulation tissue, and I was requiring some sort of airway procedure as either a stent revision or complete replacement every 40 days. And this gentleman lived about 6 hours from Cleveland, so this was not easy.
We have a problem. We have a problem because sorry, no, it's good again. Because for a while we could see Spasoje screen, but now it's back. It's back.
We're back. All right, good. All right, thank you. So, and so this was the first in human experience. We put this stent design here as a left main stem curvature with a branch point for left main stem. We placed this stent, and he didn't require a stent change for 13 months. So you can see implantation here, and this is a year later. So all the things that we were concerned about in our stenting process turned out to be great. And this is just the general concept. You have a CT scan, you make a segmented airway, you do reconstructions and find a center line. We developed a software program to do a three-dimensional prescription writing tool that turns it into a stent, into a CAD file. And then the negative of that is a mold. And then from that, we do pressure injected silicone. This very same process is done in Europe with now part of Novatech 3D. They certainly have done the majority of the work in some of the publications and actually, frankly, much more complex geometries than we do. Our FDA indication limits us to simply Y stents. But this is one of the very earliest papers where they had 40% complications, again, not terrible in the context of how awful these airways are. One mucus plugging, one migration, and one remove for cough. The description of congruence I found interesting in terms of the stent was designed based on the actual shape and geometry of the airway as opposed to what we did, which was sort of smooth it out. But when you had 90% congruence, that was considered a good alignment of the stent and the airway. Of course, as would you'd expect with stents, 80% improvement of quality of life measurements, improvement of lung function. And this certainly was, again, another large group of patients showing proof of concept improvement. And there have been a number of publications since from Nick and my group. Also, one time that we did some cases in Germany. And of course, there's a report of a couple of case series using in lung transplant and congenital heart disease. And just some pictures from some of the cases you can see. The Mayo Clinic recently published a trial of the use of the custom patient-specific Y stent in lung transplant patients. They reported 9 patients with a 78% improvement in FEV1, and 2 became stent-free after remodeling. Mucus plugging was the most common complication, as we typically see with silicone stents, but it was well tolerated, and a number of them had were their stents removed and done quite well. And of course, this is just another example of what that looks like. This is one of our patients at the Cleveland Clinic, and you can see here on the bottom, this airway was pretty bad shape. It was a stenosis endomalacia around the anastomotic line. The new stent was placed, and you can see that you look down inside the stent, and you can quite clearly see where the anastomotic line is, and that's a Y stent into the upper lobe. So you get a nice big view here. And over time, we could actually increase the size and diameter of these things to adjust for varying change in the anatomy. And of course, you got to figure out where the bottom end is so you can get the cuts just right, so you can be aware of where you may actually have opportunities to improve the prescription going forward. So if this works, then you see this little area granulation tissue. I can adjust the stent design to fix that in the next go around. And then there's been some science wrapped around these projects. This was an analysis of fit where we used cloud compare software over the different prescriptions of one of the first patients. And you can see that over time, the prescription changed, and it was really that my understanding of the patient's airway changed and or the disease was giving me different inputs. So in this particular case, we put a stent in, we upsized it, then we took it out because we thought we were going to do good, but then had to put it back in, and then eventually had a design here where you can see the red was, the stent was tightly fitting against the wall. And so the shape and design characteristics we learned over time. And then similarly here, this stent had a lot of tight parts, but then the airway remodeled. It went from 11 millimeters to 14 millimeters. So the airway started to open up and dilate. At 14 millimeters, we had a pretty good fit. So in a nice histogram here with fit in all directions. Again, remove the stent, and then when we had to go place it back in, it was pretty tight, and there's some challenges. And of course, then we modified it. So it's really of a tracking tool, more of a science project to understand congruence. So I was trying to understand the congruence concept from the French papers, And this is the best I can do to be a little bit more prescriptive. It's not really in the market. It's nothing I don't know what to do with yet, but it's sort of a research project in terms of understanding the kind of things that happen. And what I learned from this is that airway remodeling and stent geometries do change. It's an evidence of plasticity for sure. There has been at least one other device that was in the market very briefly. This was a direct 3D printed polyurethane. This company was Restore 3D. George Chang was one of the inventors of this. Ashish Maskey, one of my fellows, placed this stent in a lung transplant patient who was headed for retransplant. And then after this stent was placed in, the lung function improved so dramatically, he no longer needed a lung transplant. This is only, I think, only 1 or 2 cases ever published. The company never really took off, but it is proof of concept of a direct print. So the silicone stents have a manufacturing process where we have to do a mold first, but this was the direct 3D printed stent. What is available in Europe is not available in the United States is biodegradable airway stents. I think there's variability in the rest of the world. This is a PDA. It's a material that is commonly used in suture material, and you can see that it's a stent that you could deploy where you need it to go. There's a couple of case reports of lung transplantations early on. There were some tracheal stenosis patients, all improved. There were, however, deaths reported in the pediatric population, and there had been some early concerns about a degree of airway inflammation that occurs as these stents are being reabsorbed. Most of the reports say that it completely goes away over time, but there can be an uncomfortable transition period where there is significant airway inflammation. There was a very recent publication, like just a few weeks ago, frankly, stumbled into it in my research project getting ready for this. A German group had 18 patients with benign airway stenosis with 136 stents, meaning that when you're using benign airway stenosis and you have to use biodegradable stents, you can imagine that this is actually a series of treatments rather than a one-off procedure. 10 tracheal, 12 bronchial, mostly left main stem bronchus. The median stent duration was around 10 months. So this was a several-year retrospective study. The range up to 72 months, which seems long for stents, so I'm guessing this is multiple repeated treatments of that particular patient. The prior stenting history of 13 patients had silicone or metal stents, and of course the most common indications are the malacia and polychondritis groups, which are very, very challenging people to stent. And frankly, one of the ones that caused me the most distress in my clinical practice is just in terms of what the stents can do and what their complications eventually will be. Early complications were quite small, 4%, 2 dislocations, 1 fixed secretion problem, a little bit of granulation tissue that required therapy. And then long-term sort of matches what you think about stenting. 24.9% had granulation tissue. That was some of the early concerns with this technology, but they needed some cryotherapy. But there were no ICU deaths, emergency removals, that sort of stuff. So in larger groups, probably with some experience, they can be managed better. And so we'll have to look forward to see what more we can learn from this group and from other studies of its kind. Now, I'm not going to spend a lot of time on drug-eluting stents only because there are so many and there is so much work being done in this field. The reality is that even though this is being done, there are really very few of these available anywhere in the world that I'm aware of. But people have been trying chemotherapeutic drugs, drug carriers for sustained release of other therapies, antibiotics, anti-proliferative drugs, pretty much anything that you can sort of mix in and try to adhere to a device has been tried or is being tried, including nanotechnology. We've seen some papers there. The reality is the regulatory pathways for these things and the subgroups for whom they may be beneficial makes marketing and investment in this space quite difficult, at least in the United States. But nevertheless, it's a fantastic idea. It does have utility in other organ systems. So we have to keep an eye on this to see if one of these may come out as a clear winner with a large enough market to be successful. There is something new on the horizon. So this happened to be a paper we did, I don't remember how many years ago, 2015. This was a case report of a patient who had a lung transplant related dehiscence. And we attempted to do a standard 14/16 uncovered stent as our process. And then a week later, the patient developed sepsis, was getting worse. The necrosis is getting worse, formalizing a large hole into the mediastinum. I had read about this amniotic tissue, which is used in wound healing on the surfaces of the eye for reconstructive surgery and diabetic wounds. And I kind of thought that it made sense to try a device like this. It was open on the market. It's just a product you could pull off the shelf. And so we put a covered stent in and then laid this membrane in there. You can't quite see it, but in F3, you can sort of make out what looks like a wet piece of paper under the stent. And that was the material. We used that to cover over the fistula, put a stent on top of it. And at a week or so follow-up, it looked as though granulation tissue was starting to form, and the airway looked like it was starting to heal. But sadly, the patient died from liver failure and multi-system failure, so we didn't get a great outcome. But nevertheless, proof of concept. Turned out that we can use this amniotic tissue or its membrane products in a number of different ways to see if we can cover holes or fill fistulas, and it really is just a augmenter of healing. It's got a lot of substrate in it without any cellular components, which of course caused a company to take this idea a little further. This is AmStent. I think the company's called Patent. They are now FDA cleared for central malignant airflow obstruction. This is an animal trial done out of Mayo Clinic and University of Minnesota with Roy Cho and Eric Goodell. We're in a pig model. They had their stent placed in airway issues. There was a combination or a comparative trial to standard stents, and in the histology follow-up of these animals, they found that the amnion-coated stent had incorporated the material, had re-epithelialized the reciliated the epithelium, and there's a whole lot less information on section versus the standard thing. There was a foreign body response in the mucosa. Epithelium there was evidence of destruction and necrosis and a whole lot of airway inflammation. And so there probably is something biologically active, addition to the mechanical forces of the stent that may be ameliorated by the coating, and we don't know. And again, the prototype was our stent in the past, which did have some promise. So the hope is that this will be on the market. We think soon. It does at least have FDA clearance, but I'm not aware of anybody placing it in patients at the moment. And now, of course, the Holy Grail. There was a paper just recently, the 3D printed, biodegradable, and drug-eluting stent. So, the idea that this is potentially on the horizon is fascinating to me. And this is a great study. It's an animal study. Looked at a process where there's a biodegradable ink incorporating drugs. So they could put in pretty much anything they wanted. They had an animal model for this, did a DLP 3D printing of a material. I forgot what it's called right now. And the material was actually such that when you put it into the body, it actually triggers a thermal reaction where it becomes firm. There's shape memory, so once it's in contact, it'll adjust its shape to fit the airway. It will degrade over a biologically approved time, and they can alter some of the mechanisms by which that happens. And then, of course, how they do it and how they load the drugs, they can predict a drug release, so that fits the pharmacokinetic concept. And of course, the device will degrade over time. And so that's provided a durable, flexible radial force in an animal study. And so, this could be the future where we could have all of those things together: 3D printing, biodegradable, drug-eluting, all in one product. But very exciting to see what this may turn into in the world. And of course, the question is, where is this going? And I don't know how valid this website is. This is something I stumbled into my research. And it's suggesting that the annual growth rate for airway stenting is continuing to rise, although I think sometimes it's not necessarily a great thing. But if they're projecting that the market is 9.9 billion in 2024 and then 10 billion this year and projected to be 14 billion in the next 5 years, with a growth rate of 7.5, that's actually higher than a lot of med tech companies. And so the curious thing is this really a growth market? Is this not a growth market? Who's driving the growth market? Is it the acquisitions in the US market or other things that are coming? So, these sorts of things are interesting if you're an investor, but I don't know if that means anything in our world except to suggest that, some of these technologies, as I describe, are making a difference in some ways. The literature seems to be lagging behind sales, so we have to fix that. But nevertheless, the interest appears to be there. So, much to learn. I always remember that a stent is a foreign body and nobody is perfect. Stents require long-term management and close follow-up, and hence the optimal stent is probably the one that can be avoided. And I still, as much of a stent enthusiast that I am, but I still live by the idea that no stent is better than having to place a stent. in the appropriate clinical scenario. So with that, I'll stop. I have some cases, but I think we'll get to that to the end. Is that correct?
Yeah, that's correct. Thank you very much. So we can pass to Spasoje if he's ready.
Hopefully.
Maybe Levent, maybe I don't know if you all agree, but maybe we can comment on each because I have some thoughts and
okay. I thought we can discuss at the end of the session, but we can do as you wish.
Because I'm afraid to forget.
You'll forget.
Yeah. Please, Hervé, go ahead.
No, the first outstanding presentation as usual from you, team. Tom, sorry. But just this last sentence, the best sentence is the one that you can avoid. It's not from Dumont, but it's from me because it's it's a paper we wrote together. It's the only paper we wrote together. But he agreed on that, because I found that it was indeed the best sentence, because just to recall that stenting so far is the palliative treatment. Because it palliates the absence of a more definitive medical or surgical management. So because you have no other solution, so you can consider stenting. And I also wanted to comment on the prognostic of the increase in the market of airway stenting. I think that there is a discrepancy now in the world regarding airway stenting. In my countries, I mean, in European countries, I think, and probably in the States, there is a decrease. For us, there is a clear decrease in airway stenting in France. Well, I will just speak about France. There is a decrease for many reasons. We have to remember that the main indication is malignancy, and malignancy has shifted, from squamous cells carcinoma, central proximal airway, to more peripheral adenocarcinomas. So we found there is a decrease in the indication. Then we can focus on benign, and in fact this is clearly the main issue in benign. And in France, for instance, there is very few. It's not very common benign airway stenosis, unlike in Asia, for instance. In Asia, where a lot of TB disease. So I think that if there is an increase in the world in airway stenting, it won't be in Europe and America, but it will be in Asia. When you look at countries like India and China, they're so big. So clearly there will be an increase in these countries, and all the new development in airway stenting are focused on benign, because in malignancy most of the patients die before stent-related complications. So the WABIP guidelines state that you can place, I would say, whatever you want, it will be acceptable. But in benign, then you have really to be careful in what you place in benign. So all the new development will be focused on benign disease and not on malignancy. And I think that this kind of benign disease are more common in Asia and probably in Africa. I don't know that much about South America, but well, this was my comment, and I didn't want to forget that.
No, I agree with you completely. It seemed like a lot of our stents in the benign world, particularly the 3D stents, are surgical complications. Strictures, airway kinking, transplant, misadventures of radiation therapy that left the airways with bizarre turns. It seems to be the patients who survive some horrific airway injury that are the patients for whom we use it the most. And so that's just the idea. A lot of fistulas in the world for some reason. I don't know why. I think you're right. Not only is it that adenocarcinomas in the periphery, but I also think these new targeted therapies and immunotherapy. We've watched endobronchial disease just melt away. So I think that there are many headwinds to doing more stenting, and yet we're finding more reasons to use it in the benign disease categories. And that just stents lead to more stents, as you know. There is no definitive one-time stent. So it may be that if we're putting in more complex airway geometries in benign disease, they're going to live a lot longer and therefore get more stents. I think that's probably driving it. But you're right. I don't know that the malignant disease area indication is anything to build a business on. It's got to be something else. And then therefore we have to do better with the stents. Undoubtedly, we have to do better with the stents. So I appreciate your comments. I agree with you.
Thank you.
Okay.
Thank you. Thank you. And now, Levent, we can switch to the second speaker.
Okay.
Okay.
So the second speaker will be the good friend Spasoje Popevic. Please, Spasoje, can you share your screen?
Is it okay now?
Perfect.
Yes.
Please go
Yes,
ahead.
finally. Thank you.
Hallelujah.
Thank you so much. Thank you so much. Well, the question is hard. What can we do more with rigid bronchoscopy? But we have to remember that actually bronchoscopy started as a revolution in medicine. Why didn't bronchoscopy why didn't the development of bronchoscopy followed the development of other endoscopies? Well, there was a ban, and you will see from a short story from the start. Actually, it started 70 years before Killian. In 1828, there was a guy called Horace Green, a doctor, that demonstrated that the larynx could accommodate a foreign object without posing a threat to the patient's life. He developed a very considerable expertise in the catheterization of the larynx and trachea, and at the end, successfully inserted an elastic catheter through the larynx into the lower bronchi. However, when he presented his technique and findings to the Surgical Society of New York in 1847, it was dismissed as an anatomical impossibility and unwarranted innovation in practical medicine. And consequently, Green was expelled from the society and forgotten. In Serbia, we have a proverb that rooster who sings before the dawn usually ends in a pot. Well, that happened to Green. The conclusion of that society was that the airways are designed to allow only air to pass through and nothing else. There was practically a ban of entering the tracheobronchial tree. Well, the history of bronchoscopy actually started with a big no. And when Gustav Killian, 50 years after that, tried to remove a foreign body and make it, the history of bronchoscopy started. And as a result of a foreign body aspiration, people actually died. Why? Because there was a ban of entering the respiratory system. So we can freely say that rigid bronchoscopy originated as an interventional therapeutic procedures, remains so to this day and will remain in the future. And really, what has changed? Well, practically, let's see. Here is a doctor. There is an anesthesiologist or doctor's assistant. There is a nurse. There is a bronchoscope. There is a patient. And really, the setting is pretty much the same. Doctor, assistant, nurses, maybe equipment looks more modern, but the whole basic setting and the whole basic idea is the same. We all know what are the advantages, what are the disadvantages of rigid bronchoscopy. Of course, there is you can do multiple interventions during a single procedure. There is a possibility of ventilation and to do it through the bronchoscopy. And there's, of course, some disadvantages like limited maneuverability, general anesthesia, which is required, and especially experience and training. But experience in training is not a disadvantage of rigid bronchoscopy, it's a feature. You have to pass proper experience in training, and I will get to that later in the presentations. And of course, there are specific contraindications, and complication rate is kind of higher than in flexible bronchoscopy. But the advantage is rigid versus flexible is actually these two instruments are complementary. But we should not forget that the rigid bronchoscope is a potentially dangerous instrument, as Andrei Colt said. And while it has some things you can do with rigid bronchoscopes, there are some things you really cannot do with a rigid scope. But what you can do is magnificent. You can do practically every intervention through that metal tube, through that large working channel. You can do mechanical recanalization. You can even do some diagnostics with these ancient Schiapati 18-gauge needles. For example, in lymphoma, you mark the place if the lymph node, if you need to know exactly where the lymph node is, you mark the place with EBUS, do the EBUS needle aspiration biopsy. You are aware you need more material. Just remember the angle, and through the rigid scope, enter with this rigid needle, and you have a lot of material. Rarely used, but we use it sometimes for diagnostic purposes, but usually it's for the therapy. And we all know that we are practically, in some cases, yes, with mechanical recanalization of the major airway in central airway obstruction caused by malignancy, we are doing palliation of symptoms. But in a lot of cases now, especially with development of immuno and molecular target therapy, we are buying some time for therapy to work. In stage 4, patients with stage 4 disease can live for years, and its performance status, their performance status is actually a limiting factor. And this performance status sometimes can be very low because of the central airway obstruction. So if we remove the central airway obstruction, we are buying the time for some potential treatment to work. And of course, I will not mention the benign airway stenosis. In our country, it's usually post-intubation or post-tracheostomy stenosis. And this, in a lot of cases, actually, this bronchoscopy, if the patient is not a candidate for surgery, mechanical dilatation, in very, very rare cases, stent placement is a solution, final solution for the patient. We can do a lot through the rigid bronchoscope, as I already told you, and now we have the guidelines who says that rigid bronchoscopy is preferred over flexible in therapeutic intervention in central airway obstruction, that jet ventilation or controlled spontaneous assisted ventilation is suggested for patient undergoing bronchoscopy. I prefer the second mode. And tumor excision and ablation is recommended for patients with endobronchial disease, often combined with other therapeutic modalities. I mean, the point is that we combine other therapeutic modalities with rigid bronchoscopy, not just for palliative purposes. And airway dilatation is suggested for patients with non-malignant central airway obstruction with stenosis, and the evidence indicates that dilatation is associated with increased time to reintervention compared to other methods. But, and of course, we have algorithms, like we have algorithms for practically everything else. But like in this case, looks pretty straightforward. Mechanical recanalization, cryo extraction with rigid cryoprobe, and treating the base of the tumor with argon through the rigid scope. You always control the airway better with the rigid scope. Actually, this is impossible to do with flexible only. But what are really advantages, and what can we now do more with rigid bronchoscopy? About stents, Tom already told us what about stents. But there are some advantages in instrumentation, advantages in procedural safety, and of course, integration of robotics and imaging, and something that we rarely speak of in terms of mechanical recanalization, especially in malignant diseases, survival benefit. This paper caught my attention, and actually it's like you can do the ventilation of the distal part below the stenosis without using rigid bronchoscope for that primary purpose. So you can do the recanalization debulking with the rigid scope and ventilate with this translaryngeal tracheostomy tube called Fantoni tube. It looks like this. And the technique utilizes a very small diameter short cuff tube from the Fantoni translaryngeal tracheostomy kit, unfortunately not yet registered in Serbia. I cannot wait to try it. Placed beyond the stenosis to assist rigid bronchoscopy. And the advantages are, first, feasibility of inhalation anesthesia, which we rarely use during rigid bronchoscopy. Capnography, reliable and tidal carbon dioxide monitoring, and protection of the distal airway for contamination during tumor debulking, especially to prevent flooding from the place we work to the healthy side. So the the Fantoni tube is intubated proximal to the tumor, and the rigid bronchoscope is inserted parallel to the tube, and then you just put the tube past the stenosis, put the tube distally, do the ventilation, and do your job in the proximal airway. So this technique really looks promising to me, because we are, or in practice, we are facing like, okay, we are doing recanalization of the right main bronchus, and how to prevent spilling into the left main bronchus without moving the rigid bronchoscope, putting it back, then aspirating. And I think this can partially solve the problem. So unilateral lung ventilation without double lumen tube sounds promising to me. Then survival benefits, actually, with development of molecular and targeted therapy for the lung cancer, we can achieve with mechanical debulking only, or in patients with where we can combine different features of the rigid scope, you can actually increase survival benefit. It depends on the endobronchial type of the disease, and if the technical success rate if the technical success rate is good, then the survival will be also good. And also prognosis is better if we do it electively, not as an emergency intervention. But there can be more to that, not just removing the tumor, improving performance status. Now the patient is good for continuing immunomolecular chemoradiotherapy. Actually, this investigation showed that actually with mechanical removing of the tumor, we are reducing the number of potentially resistant tumor cells to molecular targeted therapy, and therefore improving the outcome of the treatment of the patient. So it's not just buying time, it's actually a therapeutic modality, not to mention cryotherapy that can independently has anti-tumor activity. So if we combine different interventional pulmonology modalities, we can shift from just palliation of symptoms to actual treatment of the malignant disease. And what are the challenges in conventional rigid bronchoscopy? First, maneuverability. The only way to aim tools is by tilting the bronchoscope, which can cause substantial force on the patient's oropharyngeal structures and neck. And up to around roughly a third of patients experience complications, including broken teeth, neck trauma, and achieving complex motions is really difficult, especially when multiple instruments are used simultaneously. Well, there is another thing I could mention from my own experience. You are dealing with something from the mediastinum, tumor for the mediastinum protruding into the major airway. When you are moving rigid bronchoscope up and down in the airway, doing recanalization, doing anything, you are actually moving the whole mediastinum and the tumor. It happened a lot of times that there was a problem with cardiac rhythm. The patient can develop sudden arrhythmia, even cardiac arrest, if it's not doing properly. And after and sometimes it's even enough to move the bronchoscope to restore the normal rhythm. So we are working in a very tight space where every movement has to be planned, and absolutely no sudden movements when you are doing something with rigid scope. So how to overcome this? Well, actually there is a robotic system for rigid bronchoscopy. It consists of these two arms, needle-sized, each with 3 independent degrees of freedom, so the movement of the scope itself is reduced, that can be passed through the commercial bronchoscope and used to manipulate tools commonly used in airway surgery, like laser electrosurgical probe, and this one can be used for suction or something else. You can control it with joystick, like like a robot bronchoscope, bronchoscopy system for peripheral lesions and forces, and which was very interesting to me when this was developed. Tom Gildea, of course, can speak more about it because he is one of the authors of the next article, that actually there are sensors measuring force on the airway during intervention. And results, according to my opinion, results are excellent. Initial feasibility study showed a reduction in airway obstruction stenosis from average of 75 to 14. Intraoperative forces from 80.6 Newton to 4.1 Newton on the airway, minimizing the risk of complications, and the average procedure time for robotic resections were 389 seconds with no adverse event reported. And look, it looks like this.
Spasoje, may I
I'm
kindly ask to read your presentation up?
Yes,
Your wrap up? Yeah.
In a minute. And yes, I can only quote the authors of this article that robotic bronchoscopic system in the future could have the potential to revolutionize respiratory medicine again and treat endoscopically airway dehiscence, subglottic or tracheal stenosis, tracheomalacia, and perform thoracic natural orifice transluminal endoscopic surgery. That is a level up from interventional pulmonology procedures in the airways. Thank you very much for your attention.
Thank you very much, Spasoje. It was a wonderful presentation.
Yeah.
Thank you.
Hervé?
No, it was a great presentation. I had 2 comments, but finally Spasoje, address the first one, robotic bronchoscopy. Robotic bronchoscopy, it's possible evolution. And when a few years ago, when I discussed with Ali Moussani, my good friend, but president-elect also of the WABIP, at the beginning, it seems that robotic bronchoscopy was dedicated for therapeutic bronchoscopy. Then it moved to more diagnostic bronchoscopy. And we all know now that robotic bronchoscope are focused on diagnostic, probably because the market is better. It's all about money.
Exactly.
Nowadays. And as an evolution is, I don't know if you saw the presentation of Lutz Freitag. Lutz Freitag is trying to develop a kind of disposable rigid bronchoscope. It's a plastic rigid bronchoscope. It's not fully rigid. I would say semi-rigid, semi-flexible. I don't know if it's a real good idea. I don't know, but he is working on that. Disposable rigid bronchoscope. So why not? Why not?
Yes.
We'll see.
I agree with you 100%. Why not? Well, if there are disposable flexible scopes, why not disposable rigid scopes? But there is always that problem of maneuverability, and it's a it's a metal tube inside a very tight space. So but we have to use it cautiously.
I think you show me a picture, because my concern with the robotic bronchoscopy rigid is the lack of tactile feedback. You can but now you show us a slide with sensors around, and then it changes the game, because if you can feel, if you can have a appreciation of the hardness of the stenosis thanks to the sensors, then could be a good idea.
Or you can incorporate such kind of sensors into stents. And control them from outside. That's also an idea.
I think we have to move now to the next speaker.
Thank you, Spasoje.
Thank you.
Yeah, Michael, could you?
Yes.
I have mosquitoes around.
Consent was mentioned at Springfield Hospital in Hong Kong. Today, we will explore the clinical evidence, technological advances, and surgical techniques relevant to managing early-stage lung cancer nodules, with a focus on sublobar resection and bronchoscopic ablative therapy. Lung cancer remains the leading cause of cancer-related deaths globally. The introduction of low-dose CT screening has revolutionized early detection, significantly improving survival rates. Over the decades, treatment has evolved from extensive surgeries like pneumonectomy to minimally invasive techniques such as VATS, robotic surgery, and now bronchoscopic ablative therapies. Early detection opens a critical window for lung-sparing interventions, which can improve patients' outcomes and quality of life. The Jacobaeus 802 phase 3 trial conducted in Japan compared segmentectomy to lobectomy in patients with small early-stage non-small cell lung cancer. The study demonstrated that segmentectomy was not inferior to lobectomy in terms of 5-year survival, with segmentectomy showing a slightly higher survival rate. This evidence supports the use of less extensive surgery without compromising long-term outcomes. The CALGB trial further supports sublobar resection by showing non-inferior disease-free survival compared to lobar resection in patients with small non-small cell lung cancer. This multi-center study with nearly 700 patients reinforces that less invasive surgery can achieve comparable oncological control, which is crucial for preserving lung function and reducing surgical morbidity. Ensuring an adequate surgical margin during resection is critical to minimize local recurrence risk. Resecting a small ground glass lesion is sometimes like looking for this snowball in the alpine range. We need strategies and technologies that help accurately identify our target. We will discuss localization techniques and intraoperative tools that enhance precision in sublobar resections. In multi-port VATS with a 4-centimeter wound, expert surgeons may be able to localize lesion with good anatomical mapping and digital palpation. Localizing small lung nodules during minimally invasive surgeries like single-port VATS or robotic-assisted thoracic surgery is a significant challenge. This is one of our recent clinical case of a 72-year-old ex-smoker male with a biopsy-confirmed lung cancer in the right lower lobe. It is at the base periphery and has a small ground glass appearance. 2 other smaller lesions of moderate suspicion are detected in the right upper lobe. There is always an option of leaving the small lesions behind and observe, but we will put ourselves in a difficult position when they progress 5 years later. Navigational bronchoscopic localization is a technique of choice nowadays to guide markers or dye to the lung nodule. This method enhances intraoperative localization accuracy, especially for small or deep lesions that are difficult to palpate or visualize during surgery. There is nearly no risk in this localization technique when compared to percutaneous way, which has risk of pneumothorax and hemothorax, etc. Here is what the Biflin Blue and ICG looks like on VATS with near-infrared imaging. Another effective bronchoscopic localization technique involves deploying a metallic marker just deep to the lesion. This marker is visible under intraoperative fluoroscopy, allowing surgeons to ensure adequate resection margin. This approach reduces guesswork and enhances surgical precision. Identifying the intersegmental plane is essential for precise segmentectomy. Traditionally, this was done using the inflation-deflation technique, which is less feasible in non-intubated surgeries. Injection of intravenous ICG after division or occlusion of relevant vessels allow visualization of segmental boundaries without the trouble of having inflated lungs during VATS. Additionally, 3D reconstruction software aids in preoperative planning for complex segmentectomies, enhancing surgical accuracy. The Watershed Tomography Map 2.0 is an AI-powered tool that analyzes plane CT scans to delineate intersegmental planes based on arterial and venous territories. This technology provides surgeons with a detailed anatomical map, facilitating precise surgical planning and execution. It represents a significant advancement in thoracic surgery, combining imaging and AI for better outcomes. Using landmarks identified on the Watershed Tomography Map allows surgeons to localize lesion accurately for resection if the target is close to some specific boundary. Relevant artery and vein is temporarily occluded, followed by IV ICG injection. While the boundary is being shown, surgeon would be able to localize the target. One must take care to look for the landmark quickly, as there will be cross-perfusion between the segments and make the landmark less obvious. Above recent advances in pre- and intraoperative imaging, navigational bronchoscopy and surgical techniques have created a window for us to detect cancer early and preserve lung parenchyma as much as possible during resection. Over the past decade, sublobar resection rates have increased by 42%, with an 18% reduction in conversions to open thoracotomy. These advances enable more precise and complex segmentectomies, leading to shorter hospital stays, enhancing recovery and reducing healthcare costs. Current guidelines support sublobar resection for peripheral nodules less than 2 cm with favorable radiological features or slow progression on surveillance. Parenchymal sparing surgery is particularly advised for patients with limited pulmonary reserve, multiple primary lung cancers, or significant comorbidities, including elderly patients. Transbronchial ablation is another minimally invasive technique that delivers ablative energy directly to lung lesions via the bronchial pathways. In fact, ablation is an established technique to treat malignant lesions in the lung. However, its intrinsic risk of chest wall and pleural puncture by a transcutaneous route made it not a very popular option amongst local radical treatment of malignant lung nodules. There is increasing interest and clinical evidence on transbronchial ablation technique in the last 15 years, tracing its evolution from the pioneer use of bronchoscopic-guided cooled radiofrequency ablation in Japan to recent multi-centered prospective studies. The diversity of ablation energies has been expanding, with microwave ablation gaining prominence over the past decade, alongside emerging modalities like cryoablation, pulse electric field, and laser ablation. Ongoing research emphasizes the importance of treatment outcomes assessment and identifying recurrence risk factors to optimize outcomes. The integration of multiple technologies made transbronchial ablation of lung tumor possible. Key components include the precise navigations and catheter placement within the periphery of the lung, reliable delivery of ablation energy, and real-time interpretation of ablation results. The combination of all these is crucial for improving treatment outcome. The use of intraoperative cone beam CT combined with navigational bronchoscopy is essential to the procedure accuracy and safety in bronchial ablation. The first step in the procedure is to get the good CT scan to allow visualization of the target lesion. This facilitates accurate navigation and, more importantly, the real-time assessment of adequacy of ablation. Navigational bronchoscopy alone is unlikely to be good enough to bring us to the target due to the unavoidable CT-to-body divergence. The hybrid operating room workflow integrates navigational bronchoscopy with cone beam CT to allow re-navigation upon initial failure and guidance using augmented fluoroscopy. This multimodal navigation approach enhances procedural accuracy, allowing real-time verification of instrument position and improving treatment precision. Later versions of navigational bronchoscopy, such as the Illumicide system from Medtronic, Tilt technology from Nova Galaxy, and the latest Monarch Quest, used similar approach with mobile C-arm fluoroscopy to overcome the issue of CT-to-body divergence for users who do not have access to hybrid operating room. These intraoperative CT images demonstrate the use of fluoroscopic overlay in a hybrid operating room setting to delineate pleural boundaries. Visualization of these anatomical landmarks is critical to avoid pleural injury during ablation, thereby minimizing complications such as pneumothorax. And in the unlikely event of such complication, it can be identified early and treated as needed. And as for case selection, the ideal lesion for bronchoscopic ablation would have a direct leading pathway at bronchosines to the lesion, absence of nearby major blood vessels, and hopefully a lesion size less than 2 cm in a round shape, and preferably a ground glass lesion. When there is no bronchosine, which occurs in approximately 80 to 90% of cases, navigation and catheter placement become more complex, requiring advanced techniques or tools to access and treat this nodule effectively. The transbronchial access tool is needed to create a tunnel for reaching lesions without a direct bronchial pathway. This is especially important for placement of the ablation catheter that does not have a sharp piercing tip. When the target lesion is adjacent to a sizable blood vessel, we will have to watch out for inadvertent injury to the vessel, as well as the hissing effect leading to ineffective ablation. In the unfortunate event of vessel injury, the catheter can provide tamponade to control bleeding during the process of ablation. However, significant bleeding may occur after catheter removal, complicating interpretation of ablation adequacy. The bleeding is usually controlled by routine technique. The hissing effect from the continuous flow of a nearby blood vessel potentially reduce thermal ablation efficacy. Awareness of these risks is essential for procedure planning and management. And as for large lesions with unfavorable shapes or texture, pose additional challenges for bronchoscopic ablation. The pullback ablation technique involves retracting the ablation catheter to cover a large area or irregularly shaped lesion, while bracket ablation requires repositioning of the catheter to another position to cover the lesion. Sometimes combination of these methods is needed to ensure comprehensive treatment of lesions that are not uniformly accessible or have a complex geometry. Robotic bronchoscopy offers enhanced maneuverability and precision, which may improve the ability to perform center strike or bracket ablation techniques. When the lesion is close to the pleura or fissure, a cautious approach is necessary. Slow advancement and reliance on forward microwave energy can minimize the risk of pleural puncture and pneumothorax. Additionally, pleural injury may lead to bronchopleural fistula requiring more complex management and prolonged hospital stay. After the accurate placement of catheters, effective energy delivery ensures adequate tumor destruction while minimizing damage to the surrounding healthy tissue. Heating tissue to over 60 degrees Celsius leads to irreversible cell death and thus rapidly and effectively eradicate tumor cells through the thermal injury, making it a powerful tool in lung cancer treatment. This video compares ablation zones created by microwave and RF ablation. Visualizing these zones helps understand differences in energy distribution, ablation size, and its tissue effect, which are important considerations when selecting the optimal ablation modality for specific clinical scenarios. Radiofrequency ablation uses high-frequency alternating currents to generate frictional heat, causing coagulative necrosis of tumor tissue. This slide shows a predicted ablation zone on intraoperative CT imaging 10 minutes after microwave ablation at 100 volts for 10 minutes. Such imaging allows real-time assessment of the ablation extent, ensuring adequate coverage of the target lesion and helping to guide additional treatment if necessary. On the other hand, cryoablation uses rapid freeze-thaw cycles to destroy tumor cells by ice crystal formation and membrane rupture. Pulse electric field ablation is a non-thermal technique that uses high-voltage electrical pulses to create permanent nanopores in cell membranes, leading to cell death while preserving critical structures like vessels. It creates a cellular depletion zone, or CBZ, of around 1 centimeter in diameter. Blood vessels as small as 150 micrometer within that zone remain intact, while tertiary lymphoid structure formation is triggered around the ablated region. In the INSIGHT-ES Treat and Reset trial, it demonstrated the safety of ablation with no serious adverse events related to the device or procedure. In the Pacific trial, it is believed that the immunological effect induced by PEF, such as tertiary lymphoid structure formation, is associated with longer survival, indicating promising therapeutic potential. Adverse events such as pneumothorax, pneumonia, and hemoptysis are known across the modalities of ablations, ranging from 2 to 6%. This graph presents short-term local control data stratified by lesion size from bronchoscopic ablation studies. It emphasized that smaller lesions tend to have better local control rates, and thus the importance of early detection and treatment of suspicious lung nodules to optimize treatment outcome. While sublobar resection offers a high 5-year survival and lower local recurrence rate, it involves longer hospital stays, recovery time, and greater pulmonary function loss. Data on percutaneous and transbronchial thermal ablation shows lower procedural mortality, shorter recovery, and better lung function preservation, making it an attractive option for selected patients, especially those with comorbidity or limited surgical candidacy. Patient selection criteria are recommended here. We recommend sublobar resection for healthy patients with adequate pulmonary reserve and peripheral lung nodules under 2 cm, especially when histology of the tumor and lymph node staging is important. Bronchoscopic ablation is preferred for poor surgical candidates, those with multiple comorbidities or tumor inaccessible surgically. In our experience, patients suffering from multifocal lung cancer or pulmonary metastasis may benefit most from a combination of transbronchial ablation technique and surgical resection. Using a hybrid OR equipped with fluoroscopy, cone CT, and navigational bronchoscopy, 92 patients underwent 103 procedures, treating 142 nodules in the past 5 years. Key outcomes from this hybrid treatment study are summarized here, showing a 100% technical success in ablating 142 lung nodules with a mean size of 11.8 mm and a minimal margins of 6 mm. Patients who had previous lung resection tolerated additional transbronchial ablation well and have short hospital stays averaging 1.46 days with no procedural mortality. As for the 11 patients who have concomitant transbronchial ablation and lung resection in the same GA session, the hybrid approach improved overall efficiencies, reducing operating time and total length of stay compared to those who have procedures separately. We achieved excellent local control with approximately 95% recurrence-free survival rate at the median follow-up of over 600 days. Early-stage malignant pulmonary nodules can be managed effectively with sublobar resection or bronchoscopic ablation, each with its distinct benefits. Sublobar resection offers strong long-term survival and local control, but require good pulmonary reserve and longer recovery. Bronchoscopic ablation provides a less invasive option with shorter recovery and lung function preservation, ideal for high-risk patients, though with higher recurrence rate and limited long-term data. Treatment choice should consider patients' health, tumor features, and institutional expertise. Advances in imaging and ablation technology improves outcomes. Multidisciplinary evaluation and shared decision-making are key to optimal care. Thank you very much for your attention. I am Dr. Hervé, consultant surgeon at Prince of Wales Hospital.
We listened to Dr. Rainbow Lau from Hong Kong. And we can pass to cases, Hervé. Hervé, are you here?
Sorry. Yes, this is a fascinating topic. But to be honest, I'm not an expert on that. So I'm just watching the evolution so far. So I have no personal experience, no real comments, except that, it will be the future.
Yeah, exactly. We have very limited time, so we can quickly pass to cases.
Okay.
Yeah.
Okay. Yeah. So my case will be first, right?
Yeah.
Yeah, please, Spasoje.
If you can share your screen, yes.
Hopefully. Let's. Well, did I learn my lesson? Let me see. So in this case, we use, like in every case, this systematic 4-box approach you are very long aware of. And I will just move to the case and see, and you will see in one word, why is it interesting. So this is a case of 25-year-old male with no comorbidities. He was a lumberjack, actually, and a tree fell on him. And he ended with subdural hematoma, contusion, and even a blindness because occipital cortex was injured. And due to polytrauma, he was intubated and after tracheostomized due to a ventilator-associated pneumonia caused by Acinetobacter. And in tracheostomy, he had tracheostomy closed after 5 weeks. He recovered, gastrostomy closed, and practically 3 days after the tracheostomy was closed, stridor and hoarseness developed. Flexible bronchoscopy was done in general anesthesia, and it was either post-intubation or post-tracheostomy stenosis. Total diameter of the trachea was around 6 millimeters. And as you can see, very tight airway and very low actually position for tracheostomy. So what we did decide, proceed to, when we saw the lesion, and there was a lot of granulation tissue on the edges of the stenosis, we decided to proceed to rigid bronchoscopy with sequential mechanical dilatation, starting from size 6, for example, rigid scope, to maybe 7.5. We had everything ready, and there was one thing which was concerning me at the time, that the tracheostomy was closed 10 days before the procedure, so we will be maybe dealing with unstable anterior wall of the trachea. And of course, there is always risk of bleeding, tracheal perforation, and anything else that's pneumomediastinum. And alternatives to the procedure are described to the patient. Surgeons were really reluctant to do the surgery before we or try to dilate or to pass the stenosis with a rigid scope to see how it will go later. So and because of the condition of the patient, he was it was after severe polytrauma. He was recovering after severe polytrauma. And we have a set of very small bronchoscopes for children, and that we use for dilatation. And here is the first part. You see there is a lot of granulation, fresh granulation tissue at the edges of the stenosis. This is 6, bronchoscope 6. Then we continue with 6.5, and you already can see that trachea is slightly collapsible at this part. So we decided to stop. Why? Because we can cause a localized tracheomalacia. I think we need that thin fibrous ring to make this trachea open, because remember, there is unstable, probably unstable anterior wall after tracheostomy. This is the end of the procedure. And you can see we did a decent job recanalizing just enough to restore airway patency. But the problems when the patient woke up, he was not really breathing much better. There was still kind of hoarseness, there was stridor, even a little less, but it was still present. So what did we miss? We decided to assess the dynamics, to do the bronchoscopy, but to see how the airways are moving during this bronchoscopy. Remember, every bronchoscopy in him was done in general anesthesia. Now we decided to do local anesthesia, analogous just sedation, but like conscious sedation, and we did control flexible bronchoscopy, and we found the reason. The reason was vocal cord paralysis. Actually, as a result of his brain injury, a result of his polytrauma, he had vocal cord paralysis, which went unnoticed because no one did bronchoscopy in local anesthesia. Everyone was doing bronchoscopy in general anesthesia. So we need to assess the whole airway. That is the whole point, to assess the whole airway. And after we evaluated the results, actually patient went to phoniatric rehabilitation. After that, he underwent surgery with resection of the trachea with terminal anastomosis. And actually he's doing practically much better and normal now. So what are the points of this case? First, rigid bronchoscope is extension of your brain and your hands, not of your ego. The point is we recanalized the airway, but patient was not breathing good after we removed the scope. So we cannot, we should not look for mistake in the patient. We should we should assess we should reassess what we do. Second, beware of the post-tracheostomy stenosis. Damage to the anterior wall after tracheostomy, we can cause localized tracheomalacia. So we have to be moderate with recanalization, not to 100% of the lumen, just enough, and then we'll see how it goes. And the first bronchoscopy in these patients after that was my, like, only in conscious sedation with spontaneous breathing. That was my case. Thank you.
Thank you very much, Spasoje.
Thank
Tom,
you.
please accept our sincere apologies, but we have exceeded our time hugely. So we can pass to the next session. Hervé, please, can you wrap the session up?
No, because I don't have the program. So
We exceeded our time.
We have
Usually.
exceeded. Sorry, but because we are all passionate by what we are doing, and it's very difficult to stick to the time.
You're right. You're right.
Exactly.
Above all, it's Sunday. It's Sunday, so we have no operating room, no consults, but time is time, and
Yes.
so sorry for the cases. I just answer one question. If some more questions have to be asked, but don't hesitate to use the answering question system.
Thank you all. And next we have the third session, bronchoscopy for benign lung disease, with chairs Dr. Alvin Ng from Australia, Professor Felix Hervé from Germany, and Professor Carl Lamb, United States.
Thank you all.
And I believe, while Dr. Felix Hervé, I think, is not here, Carla and Alvin, if you do us the honors.
Oh, sure. Thank you. It's my privilege to be invited by the chairs for this conference. I see my background is flipped and I cannot unflip it. So if anyone's distracted, and Michael, if you can do that, that would be wonderful. But I'd love to introduce our panel. So our focus will be on benign disease today. And I'm going to introduce our first speaker, Dr. Alvin Ng, who probably needs no introduction, but I am going to honor his introduction. He's the professor of respiratory medicine and health sciences at Macquarie University in Sydney, Australia. He's also the clinical program chair and head of cardiovascular and respiratory program there as well. He's been quite prolific in his innovations in managing COPD with valves, coils, vapors, denervation. And he's also widely recognized for all of his work in advanced bronchoscopy, airway management, minimally invasive techniques for both diagnostics and for therapeutics. And he's continued to shape practice and really set the stage not only in Australia, but globally. And it's my pleasure to introduce him as our first panelist. Thank you.
Carla, thanks very much. I feel a bit intimidated speaking on the same session as the president of the AABIP and the president of the WABIP. So I'm just I'm not president of anything, but I'll do my best to try to enlighten you on COPD. So I might just share my screen. Right. Okay. So I hope you can see my screen. But I'm talking about bronchoscopy for COPD, and there's many sort of different aspects to this. But in the 15 minutes I've got, I thought I would focus on what I thought was some innovations in the area. These are my disclosures. Basically, I'm the principal investigator of a number of different clinical trials, some of which I'll speak today. And rather than acknowledge my sort of co-investigators at the end of the speech, I might acknowledge them now in that these are my co-workers, and none of which I'm talking about tonight I could do without them. So thank you to them. So this is the current gold guidelines for recommendations for interventional therapy in COPD. And if you look at bronchoscopic interventions, you'll see that valves, evidence A, lung coils, evidence B, vapor ablation evidence B, really on the back of one's a randomized control trial. And I'm not going to speak about valves tonight, mainly because we've been doing them for over 20 years, and there's plenty of good RCTs. And I don't think there's any controversy as to where they should be done and how they should be done. So I'm just going to focus a bit on other interventional therapies, particularly.
Kelvin,
yes.
sorry. I think your slides are on presentation mode.
Oh, okay. So that's not what you want. Is that better? Is that any better, Pyng?
Yeah.
Okay. Is that a better format for us?
Yes, because it's a single slide. Just now we can see your oncoming slide, your next slide.
Okay, no worries. Okay. So this I might just try see if this works. And if I put in presentation mode now, how does that go? How's that?
Yeah, I think you should click onto that button.
Okay, no worries. Okay, so I'm going to start with this. So this is the usual assessment of COPD that we do with our automated analysis of emphysema destruction scoring. And this is a typical valve patient in that you can see that there is quite significant destruction of the upper lobe, and there's significant heterogeneity, and the fissures are complete. And you'll probably target right upper lobe or right middle lobe because there's greater heterogeneity on the right, and there's a complete fissure on the right as well. And what we're trying to achieve is volume reduction. We're trying to achieve targeted volume reduction in the targeted lobe. And this is what we would like to see if the left upper lobe's a target, significant volume reduction afterwards, mainly because that if we achieve volume loss, then that is associated with improved symptoms and most importantly, improved prognosis and survival. And there's been quite a number of studies that have shown that. Now, so far we've looked at these section of the decision-making tree where you've got complete fissures, and then valves are appropriate if there's heterogeneity. If there's homogeneity, then there is some evidence, and it's generally accepted that it's still appropriate, but the response is probably not as good as if you've got heterogeneous disease. What I'm going to talk about for the rest of my talk is patients with incomplete fissures, patients with fissures between 80 to 95%, and even fissures less than 80% complete. And this is the typical patient that we would consider. So about half the patients that come to us for ELVR assessment are not suitable for ELVR, mainly because of fissure incompleteness. So about half our patients, if they fill other criteria like lung function criteria and 6-minute walk criteria, they're not suitable for a lung volume reduction because of incomplete fissures. So we wanted to think of a method whereby we could address this so that we could offer lung volume reduction to more than half the population that are basically referred to us. So this is a patient that has incomplete fissures on the left, 83%, incomplete fissures on the right, 84%. And the question is, they're not suitable for valves. What are the options? And we published a case report of a proof of concept where we would use a polymer sealant to try to seal the fissure defects before inserting valves. And this was a proof of concept publication. Now, biopolymer sealant has been used in the past for lobar volume reduction about 15 years ago, but as most of you know, although it was effective, there were adverse reactions. So we wanted to see if we could achieve some segmental atelectasis sealing fissures without the side effects by reducing the dose that was given previously. And in this patient here, you see there's fissure defects in the left. You can actually see the fissure defects on a CT scan. And what we can do is we can actually determine what segment or subsegments lead to that fissure defect. And in this case, it's LB4 and LB5, about 50-50 between those two segments that supply or sub-10 that fissure defect. And when we do Chartis, you can see that there's continued flow. This is our proof of concept patient. And then we used foam polymer, combination of polyvinyl alcohol and glutaraldehyde, mix it together and get a foam, and then inject the foam into, in this case, the lingula. And what happens after that is a month after that, we perform Chartis again. And this is actual signal from the actual patient itself. Very clearly a decrease in flow over time within 2 minutes. So converting from a patient that had collateral ventilation to a patient that didn't have collateral ventilation. We put valves in afterwards in LB123 and LB45, and we got significant volume loss as desired in the left upper lobe. So we published that case, which then led us to do a parallel control study comparing patients with complete fissures who had valves to patients that had incomplete fissures who had aerosol or polymer foam installed to seal the fissure defects and then valves afterwards. And we had different types of fissure defects. In this case, that fissure defect there is entirely subtended by LB5. And in this patient here, the fissure defects are clearly over more than one segment. And LB12, 24%, LB45, close to 70%. So we had different types of fissure defects, and we mapped those fissure defects to the segments. And what we found is that when we compared both groups, those that had valves because they had complete fissures compared to those that had foam polymer sealant before having valves, there was really significant improvements across most of the parameters that you expect in lung function, in reduction in residual volume, improvement in 6-minute walk test, improvement in SGRQ, and you can see the magnitude of the changes there. But the important thing was that there was no significant difference between the two groups, apart from a slightly better improvement in FEV1 in the control group, those that had valves without the polymer foam sealants. And this is just an X-ray example of the series that you see. This is baseline X-ray. This is after installation of the polymer foam sealant. There is a little bit of volume loss after that. A month after that, the inflammation resolves. It's the inflammation that causes a segmental atelectasis that causes the fissure to be sealed. And this is what it looks like after valves. On the back of that, some of you would be involved in the multinational, multi-center trial, CONVERT-1, which has finished recruiting. The actual results were presented at ERS last year, where 101 subjects were enrolled, average age of 65 years, FEV1, as you expect, at 30%, RV high to 136%. Fissures were incomplete, between 68 to 87% incomplete. 77% of those patients with the polymer foam sealant went from collateral ventilation positive to collateral ventilation negative. And there was also a significant reduction in mean targeted lung volume, as well as significant 89% achieving a mean clinical important difference of minus 350 mils on residual volume. And on the back of that, CONVERT-2 is now being conducted, again, a multinational study across North America, Europe, and also Asia. And those results will be interesting to see in a few years' time. So I've talked briefly about this now, the 80 to 95% fissure. What about when you've got fissures bigger than 20%? What if there's less than 80% completeness? What are the alternatives? So this is a patient that would be suitable for that. As you can see, the fissure there is 75%. There is a little bit of heterogeneity there. What do you do for these patients? So there's thermal vapor ablation, which has been around now for probably 12, 13 years. And that is the installation of steam into the targeted segment, not the targeted lobe. So there's a bit more finesse in targeting. And the steam is delivered via a balloon, so there's no back leaking of the actual energy. And the amount of steam delivered is determined by the volume you're treating, as well as the density of the lung that you're targeting. And this is a paper published almost 10 years ago, an RCT, which looks at improvements in FEV1 at 6 months and 12 months after BDVA compared to a control group, as well as improvement in SGRQ. And it's on the back of this study that the evidence B recommendation for gold guidelines was given. And instead of targeting lobe, BDVA, thermal vapor ablation, targets segments. So for example, if you were trying to map out what you would target in this patient, you would target RB1, which is 57% destroyed, RB3, which is 49% destroyed, but you leave RB2 alone. Similarly, if you're targeting the left lung, you would go for LB3, LB5, and not the rest of the left upper lobe. So you can see it's a bit more subtle than lobar. It's probably theoretically, at least, potentially more effective because you're not treating a whole lobe where one segment is reasonable. You're actually treating the segments that are most destroyed rather than a lobe which is much more mixed. We did 13 patients in our registry. Unfortunately, thermal vapor ablation is no longer available in Australia because it's lost its governmental approval for non-clinical reasons. But our results mirrored those of the publication, where there was improvement at 6 months in FEV1 and not FVC. There was a significant reduction in RV, improvement in both in 6-minute walk test and in St. George respiratory questionnaire. So this is a non-controlled prospective series. These are the changes you get with thermal vapor ablation. You'd get targeted segmental atelectasis from inflammation, but it's not without its risk. This is one patient that actually presented with significant hemoptysis following thermal vapor ablation, one of our first patients. And you can see there's a lot of destruction that can be potentially present. And hemoptysis is a problem. And in fact, those centers doing thermal vapor ablation now would exclude anybody with on anticoagulants or anybody on aspirin, anybody on antiplatelet agents because of the risk of hemoptysis afterwards. So it's not without its risk, and COPD exacerbation is the other potential complication. The other technologies are very similar to thermal vapor ablation, is endoscopic thermal liquid ablation. And it's a very similar type of energy delivery. Instead of using steam, it's 95 degrees saline. So because it's liquid, it has a slightly different distribution of its energy. But the patients that we treat are very similar. Those with incomplete fissures who have significant segmental heterogeneity. And just like BDVA, we treat by segments and not by lobes. The delivery volume is the energy amount, and that again is determined by both volume as well as the tissue density. 33 patients have been recruited in Australia, and the publication is preparation, but it's not been presented at any major conferences yet. So who is thermal vapor ablation or thermal liquid ablation for? Patients with severe and very severe COPD, FEV1 20 to 50%, residual volume greater than 175%, patients that have incomplete fissures, and patients that have nickel allergy, because if you have a nickel allergy, then obviously the nitinol valves are contraindicated. Patients with segmental heterogeneity, but again, there are safety concerns, particularly the risk of hemorrhage, and that needs to be taken into consideration. If you can't stop antiplatelet agents, then they probably are not a candidate. In my remaining time, I'm just going to talk about a paper that was recently published. It's about the airway scaffolding, which was published only a couple of months ago in the Blue Journal. And that looks at a nitinol device called airway scaffolding. It doesn't have the intrinsic elasticity or the firmness of stents. In fact, it's designed to prevent small airways from collapsing. So the major indication is patients that have large cystic disease, which are due to gas trapping, and this allows the potential treatment of gas-trapped areas by allowing them to vent through airways that otherwise would be closed. So again, it's segmental delivery, and it's a step-up type protocol. The patients have 2 procedures separated by a few months, and it's up to 3 coils or scaffolds into each of the affected segments, maximum of 3 on each side. So in this patient here, we would treat RB1, RB2, maybe RB3, but we would leave right middle lobe, right lower lobe alone. And on a subsequent therapy, we would probably treat LB1, LB2, and possibly LB6. So that's the sort of mapping sort of strategy that goes with the treatment strategy. So this is a example of how it's delivered. It's delivered through a therapeutic scope. This is TH1100. And you place the delivery catheter within 2 centimeters of the pleura. You don't want it within 2 centimeters, otherwise there is a risk of pneumothorax. And then it's delivered, and you can see that gradually expanding there. That's the airway scaffold. That's what it looks like inside. And this is approximately, and obviously there's a little knob on an internal, which means you can pull it out if you've misplaced it, or if there's any other reason that you may be worried about. We were worried about the potential of granulomas, given that uncovered nitinol stents in the large airways are notorious for granulomas. But we've been doing repeat bronchoscopies at 6 months and 12 months for these patients, and we have not seen granulomas, and we've seen some of these devices become epithelialized. And we actually inspect the actual scaffolding, as I mentioned, at 6 months, at 12 months. We use an ultra-thin MP190 scope. We put it through the actual scaffold, and you actually quite interesting to see alveolar space sometimes, because you can get to the periphery through these scaffolds where you wouldn't do so normally because of small airways closure. The results, these are waterfall plots. 54 patients presented in the Blue Journal, 98 procedures, 328 airway scaffolds. So at 6 months, significant improvement in FV1, or not in everyone, but it is significant in a cohort, significant reduction in residual volume, and significant reduction in RV-TLC ratio, and improvements across the board in symptoms, as well as 6-minute walk test. It's not without complications, as with every new technology. Pneumonia in 6 patients, COPD exacerbation in 4 patients. We've had a significant pneumonia in one of our patients that needed hospitalization. COPD exacerbations is uncommon, and it's treated along standard lines. And the rest are one of each of these. So the only other thing I should mention is that sometimes there is a bit of sputum retention, and when we did repeat bronchoscopy with our patients, we did have to aspirate some sputum to prevent airways collapse. This is our first patient, just to give you a individual sort of type of response. Their baseline FEV1 was 0.54, improved to 0.66 after the first procedure with 3 scaffolds. No improvement after the second procedure. But residual volume decreased with the first procedure, and perhaps decreased a little bit with the second procedure. So that's a magnitude of changes that is representative, and it's something that obviously needs a lot more work, a lot more study. This was, again, just a prospective series without a control group. So I'm going to end my talk there. I don't think I have time to talk about denervation, which is also another interesting area, but I thought I might end my talk there, and happy to take further questions or discuss this during discussion. Thank you.
Thank you so much, Dr. Ng. That was quite innovative and very comprehensive. I think what we'll do, we'll have all the speakers speak, and then we'll have time for Q&A. And I would encourage anyone in the audience to send your questions into the chat or the Q&A box, and we'll take a look at those. And we'll, as time permits, we'll certainly address those. Thank you so much.
Thank you, Carla. So may I take the reins now and introduce Carla, who I mentioned is the president of the AABIP. And is also Director of Interventional Pulmonology at the Lay Hospital, I hope I pronounced that correctly, and the Medical Center, and that's in Burlington, Massachusetts, United States. So, Carla, thank you very much for your presentation, which I believe is on bronchoscopy for ILD. Thank you.
Yes, thank you. I'm just going to share my screen. Let's do that. I'll just do a quick check-in to make sure everyone can see my screen.
That's good, Carla. I can see it. Thank you.
Okay, wonderful. Thank you. So I'm going to focus on the next few minutes on bronchoscopy and the role of it in ILD. Have no disclosures relevant to this topic today. And the objectives are going to be fairly straightforward in that we're going to review the strategy for bronchoscopy and ILD and how we've evolved over the last decade in terms of moving forward to standardization, less invasive means of making a diagnosis, highlight the cornerstone of multidisciplinary approach to patients who present with ILD findings. And the integration of AI has brought us a long way in earlier detection of patients who have interstitial changes on CT scan, namely high-res CT, and also talk about highlight the evolution of less invasive techniques and the spectrum of biopsies that have evolved and what our practices are looking like globally. I think this is very relevant to just remind us of how heterogeneous the patients are and the disease and the diagnoses and the treatment algorithms for these ILDs. And so I think with that, oftentimes these patients are late to diagnosis and therefore late to treatment. So as we move on to standardize how we think about the patients in a multi-D approach, and I'll talk about what a multi-D team would look like, it's imperative that we, as those who do bronchoscopy, try to maximize and optimize what we are doing during those procedures. And oftentimes these patients will not necessarily need to go on to surgical lung biopsy and have a less invasive approach to their care. I think this is just a relevant snapshot to remind us of the wide spectrum of how ILD looks. Sometimes it's diffuse, sometimes it's ground glass, sometimes it's classic honeycomb in the periphery, sometimes it's very localized, sometimes it's coupled with malignancy. It can run the spectrum of environmental, autoimmune. Sarcoid is probably one of the most common that reaches out and affects lots of patients. And I think that in drug-induced disease as well. And then, of course, idiopathic. So what's the strategic way of looking at this? Well, we have evolved in terms of how we think about who needs a biopsy. In high-res CT scan and the integration of artificial intelligence is helping us to be better at when we're calling this and also augmenting the radiologist approach. But I also think that not every patient needs a biopsy, and that's where the multi-D team comes in. And what does the multi-D team look like? It really should be a chest radiologist, pulmonologist, interventional pulmonologist, and advanced bronchoscopist, thoracic surgery, pulling all those different footprints together, as well as rheumatology. I think that makes a robust discussion and also has a really 360 way of looking at patients. We're going to talk about the different ways of biopsy with bronchoscopy. Traditionally, it's been transbronchial biopsy with forceps, but now with the evolution over the last decade with cryobiopsy and the evolution of the size of the probes, that has lowered the risk and increased the diagnostic yield, and we'll talk about that comparatively to the gold standard, which is surgical lung biopsy. I do think it's important to think about how we're using genetic markers, and Envisia is one of those that's used to integrate with. In certain cases, it's a rule-in test for UIP. I'll talk a little bit about that during this presentation. So when we think about the steps, here's the general framework and the standards that we're moving toward. The high-res CT is important. Supine and prone techniques important for that. Maybe the biopsy won't be needed. If it's indeterminate though, and the patient's stable and doesn't have a rapid progression of disease and can tolerate such a procedure, then we move on to bronchoscopy. While I'm going to focus on biopsies, we don't want to forget that BAL can have a complementary role, especially for hypersensitivity, for drug-related ILDs, and even for sarcoid, but often is not standalone diagnostic. We also don't want to forget in the role of sarcoid for endobronchial biopsies, in addition to the transbronchial approach as well. And also, we'll talk a little bit about cryo as that pertains to lymph nodes in the setting of ILD and those ILD patients who actually have adenopathy as well. And then if the transbronchial lung, this is a TBLC is really representing the cryo form of biopsy. If that comes back non-diagnostic or it's contraindicated, and we'll talk about some of those contraindications, then surgical lung biopsy still is something that should and could be offered. I'll move on with the next component. So the modalities I've kind of alluded to already. We also will talk a little bit about the evolution just in the last few years of really navigating out further into the periphery for more when ILD is not diffuse, looking at robotic techniques in complement with the radial ultrasound probe, OCT, optical coherence tomography for a image biopsy, if you will, that's evolving, continues to evolve in this space. So transbronchial forceps biopsy, the pros are it's widely available. Many people are trained. It's considered safe, although of all the different procedures we do, it carries the higher risk for bleeding and pneumothorax of all the procedures we might offer, but it can have a high diagnostic yield in certain ILD diseases. The cons is feedback from pathology will be small sample. And also would make sure I add to the multidisciplinary team, having a pathologist in that disciplinary group is important as well. But crush artifact with the forceps can be problematic, making a diagnosis with small samples. And we'll highlight some of the guidelines and some of the most recent literature and the evolution of the literature that supports the evidence behind what we're discussing today. So comparative evidence, I've already kind of talked about TBBX can be low yield for UIP specifically, but can be high yield in ruling in or ruling out infection, and also for sarcoid. Cryobiopsies transbronchially has proven over time a more robust diagnostic yield for larger sample size, absence of crush artifact, and higher quality samples. Surgical lung biopsy will still remain gold standard, but the cryobiopsy is really giving that a run for its money. And we'll talk about that in just a moment as we bridge these gaps. So cryobiopsy, it is clearly an alternative to the lung biopsy in expert centers. And this is the key. When we're doing cryobiopsy, when you look at the data, it's highly varied, it's very heterogeneous. And when you try to do a meta-analysis on this data, it's sometimes hard to conclude. But there are some signals of best practices, and I'm going to highlight those takeaways today. So diagnostic yield, if those guidelines and those suggested best practices are followed, can render 75 to 85%. Larger samples, lower morbidity than surgery, those seem obvious. I'd also say the pneumothorax rate, again, would be variable, and with a smaller probe and more augmented guidance, we'll talk about that with cone beam, CT imaging, tool in lesion, tool in pathology. We can sometimes mitigate further the risk of not only pneumothorax, but bleeding and by visualizing vascularity nearby the biopsy sites. We'll talk about safety, prophylactic balloon occlusion, and how that's also evolving. The cold ice trial was pivotal in looking at the diagnostic concordance when compared to surgical lung biopsy. So again, I've mentioned the gold standards. I won't belabor that. And it's still a tool in the toolbox, but I think we've markedly changed the face of how we manage the patients with ILD, and many no longer need surgical lung biopsies. So comparative diagnostics, I think this is important. I've included EBIS TBNA only because it can be an augmenting diagnostic tool, either TBNA with needle or cryobiopsy of lymph node, to really augment an ILD workup in patients who have adenopathy in conjunction with their ILD findings in the parenchyma. The cryo-EBIS is representing the transparenchymal biopsy there, and then the transbronchial cryobiopsy, as well as the cryo-EBIS biopsy, is delineated here as well. A little bit about yield and complications. This is based on many different meta-analysis in the literature. I've referenced all these at the very end of my talk, and really kind of a must-have list, if you will, of references and go to published peer-reviewed articles. This kind of highlights the evolution of reduction in bleeding as we move further into less invasive options here. Things that are evolving very rapidly are used in complement currently, but more data will need to evolve before we can say that this is guideline level. But robotic bronchoscopy, getting further out into the periphery when there's patchy disease, utilization of cone beam or other augmented radiographic in real-time technology so that we can actually see tool in lesion, know where the boundaries are more safely. OCT can also provide kind of a complement to a tissue biopsy, but does not yet replace an actual biopsy for histopath. I'll talk about the Envisia in just a moment. So Envisia genomic classifier, what is it? Molecular diagnostic testing analyzing 190 RNA gene expression. So it actually can be used as a rule-in test specifically for detecting UIP. Has a specificity of 88%, sensitivity of 70%. It can work in complement with transbronchial biopsies, whether they be with forceps or with cryo. There is more growing body of literature showing that the cryo biopsy as the form of biopsy used for the Envisia genomic classifier, that this is actually a test run on a parenchymal sample. It's also helpful when high-res CT, as I mentioned before, is indeterminate, but it really is a test for ruling in and separating UIP. This is just an abstract that was published a few years back showing the complement where patients who underwent combination of cryobiopsy transparenchymally bronchoscopically and with the Envisia augmenting that many patients did not require going on to surgical lung biopsy for definitive next steps for diagnosis and ultimately treatment. So here's the practical part of this talk, safety and technical checklist. We all should have one, and this is what we all should be striving for if we're working toward being a center of excellence. If we're offering cryo EBUS, obviously we can use Doppler on our linear EBUS to identify within lymph nodes any vessels, and we isolate a freeze time for 3 to 4 seconds, and we pull the scope out on block to optimize the volume of the sample. For transbronchial cryo, again, this is an evolution, and I think as data bears out in the future, we may find, typically the bleeding rates were much higher quoted when the larger probes were being used, the 2.9 millimeter, for instance. And now there's a spectrum of reusable probes, 2.9 and 1.7, and then disposable is really typically now we're using the 1.1 millimeter, even though there's a spectrum of sizes as well. But a lower or smaller probe size has equated to higher level of safety, reduction of bleeding in these patients, and also reduction or comparable reduction between the 1.9, 1.7 for pneumothorax rate. The freeze times can vary. I think this is just kind of, again, a benchmark for safety. Utilization of the radial probe and then some other radiographic tool to augment your view, which would be both fluoroscopy and or cone beam CT or other augmented fluoroscopy. I've already mentioned the Envisia, so I won't go into further about that. So what are the absolute contraindications and relative contraindications when we're thinking about approaching a patient for biopsy? Some of these are quite obvious. You correct the things you can, but the relative contraindications need to be paid attention to as well. And this is really as a matter of function. Does the patient truly have reserve should they suffer any form of complication from any type of biopsy, which kind of holds true for standard practices for any TBBX. So what are some various techniques that have been published in the literature and have been proven over time? And these are generalities. There can be some variances, but I think a combination of the flexible scope, cryoprobe, radial EBUS. And I think in patients, whether you're using a rigid bronchoscope or you're using an endotracheal tube, you're choosing a large endotracheal tube, 8.5 or larger. And you're making sure that if you are using one of the larger probes and you're not necessarily using a robotic approach, that you either can a priori prophylactically placed an endobronchial blocker for safety in between the passes of the actual cryobiopsies for safety to keep contained if there is undue bleeding. Freeze time, as I've mentioned, and then balloon blocker, as I've mentioned. And then when we sample, we're thinking sampling ipsilateral on the same side, 2 different locations to enhance diagnostic representation of the samples. Again, this is just a snapshot published, and there's evolutions of this looking at if you're setting up your cryobiopsy program, certainly while you could do these under mod sed, I would say by and large, general anesthesia, a non-coughing patient, a secure airway really lends itself to a more successful procedure, and that's been proven in the literature as well. From here, I'm going to talk a little bit more about, I'm going to kind of go through in the interest of time, a little bit more practical points of the cryobiopsy. I'll move through this. This is just kind of the setup. This is the 1.1 millimeter probe that is being much more commonly used for this effort with a flexible bronchoscope through the working channel. And I've mentioned, again, localizing the disease, taking the samples. This is just an example of having a prophylactic blocker and being able to wedge in for safety if necessary. These are just some of the signals that can be seen with variations of different forms of ILD. And these are things that are really pattern recognition. Those of us who've been using radial EBUS are quite familiar with these patterns. This is just a correlate between the ultrasound view, the CAT scan, and the histopath of various forms of ILD and the wide-ranging appearance of things. So I'll briefly, in the wrap-up of this, I'm going to just review a little bit more about some of the risk-benefit analysis that's been published. Again, you'll see here, I'm drawing attention to the difference here is the larger probes, higher risk for bleeding, higher risk for pneumothorax, but now there's an evolution quite quickly to go to the less than 1.9, 1.7, and 1.1 millimeter probes. This is just a highlight to reflect the complication rate varied between forceps biopsies and cryobiopsies. This also is a comparative between surgical lung biopsy or VATS and transbronchial biopsy with cryo. This is the cold eye study that was well published and really has become a cornerstone and has really evolved what we are doing with cryobiopsy for the purpose of ILD. And again, enhances kind of the algorithm that I mentioned earlier at the top of the presentation of how we can decide and divide and stratify the patients who go on to biopsy. Pneumothorax rates quoted here again. I would say now with cryobiopsy with smaller probes and under direct guidance with imaging in real time, we're seeing a far less rate of cryobiopsy-related pneumothoraces in the order of less than 6%. Transbronchial bleeding, I would also say the evolution now has become much lower, again, with focal disease and also using smaller probes, but also having those prophylactic measures in place if necessary. Mortality, quite low. This is a really very feasible, and these are safe procedures if done with pre-planning, as I've mentioned. This is just a little bit of a footprint about using navigation to make us better. It certainly has made us better for the pulmonary nodule. I would say it's evolving its use primarily in patients who have ILD that's very more localized and focal and less diffuse. These are just some studies that I think are relevant to consider, again, looking at the meta-analysis, trying to synthesize the data and how we manage patients with ILD for diagnostic purposes. This is more informational, as I've highlighted. And then I'm going to wrap with a little bit about cryo-EBUS for mediastinal lymph nodes. And I think, again, when we think about ILD and adenopathy, the most common disease is clearly by and large sarcoid. And it can enhance the diagnostic yield for patients when you use it in combination or as a standalone in some cases. The cryo probe that we use for mediastinal lymph node, I think it has evolved also, and it's 1.1, the freeze time's 3 to 4 seconds. We extract the scope on block. Bleeding is usually rare and minimal, especially paying attention and not biopsying areas that have lots of vascularity, trying to be proactive in that regard. This is just an example of showing the cryo probe in a large lymph node. Here you can see the radiopacity there of that. This is just some histopath representing that. So to wrap it up, I think we've come a long way. We've evolved how we think about ILD patients. I think we're getting better at recognizing the disease, naming it, being more definitive about the diagnosis rather than letting these patients kind of smolder along, undiagnosed when there are treatment options that could prevent progression to lung dysfunction. And you can catch these patients before they become really grossly symptomatic, which I think is a game changer. These are just references for the audience. And I was asked to do a presentation, but I'm going to hold the presentation to the end of the group, and I'll stop sharing now. Thank you.
Thanks, Carla. That's a wonderful, comprehensive and very structured way of looking at bronchoscopy for ILD. Would you say that in your experience now that surgical biopsies are pretty rare? Very few patients have had cryobiopsies had to go on to surgical lung biopsies?
I would say yes. I think there's still a place for surgical biopsy. And I guess what I would leave for the group for that question. If you do, there actually is a study that came out looking at transbronchial biopsies. If it was not conclusive, there would still be a role to consider a repeat bronchoscopy with cryobiopsy even before surgical. That's a new part of the algorithm that you always often wonder, is there a role for a repeat bronch? And in this instance, based on a few studies, it would suggest that there may still be a role for a repeat bronch specific to do a cryobiopsy. But I think the patients, if you still are needing a diagnosis and your biopsy has not rendered it with cryo, then I think surgical biopsy clearly has a place, and it still remains the gold standard.
Thank you very much, Ta.
Thank you. Thank you.
I might introduce the next speaker now, Professor Pyng Lee, who is the president of WABIP, as well as the professor at National University of Singapore and director of interventional pulmonology there. I might add that Pyng's going to talk about bronchothermoplasty as well as biologicals. And I'd like to thank Pyng for actually mentoring our first bronchothermoplasty procedure at Macquarie, I think about 12 years ago. So it's good to hear you talk about thermoplasty. It's also be interesting to see what you think the future of it is. So thank you, Pyng.
Okay, can you see my slide?
I can't actually, I'm sorry.
Oh no.
It did briefly come up while Carla was talking, but it's gone off again.
Okay. How about now?
Now I can. It's good.
Okay. All right. So I'm going to talk about bronchothermoplasty versus biologics. This is something that I feel it has been very little representation, especially in guidelines, because worldwide, asthma burden is really very high. 400 million people suffer from asthma. And asthma, although it is a benign disease, deaths can occur, and it constitutes about more than 250,000 deaths per year. And in the United States, approximately 9 people die from asthma per day. So what is asthma? Asthma is a chronic inflammatory disorder that we all know about, where many cells play a role. And in susceptible individuals, it is the airway inflammation that results in airway hyperresponsiveness and with time airway obstruction. And when it happens, this persistent inflammation can cause airway remodeling, and this takes place in the form of basement membrane thickening, collagen deposition. More importantly, there's smooth muscle hypertrophy. And with time, airway remodeling really leads to irreversible airway narrowing and persistent airflow obstruction. And we look at the GINA guidelines. Bronchothermoplasty at this present moment is only indicated for non-Th2 severe asthma, where they do not respond to all these interventions, or in Th2 severe asthma, where they don't respond to the biologics, okay? And the definition of severe refractory asthma is important because this usually is featured in the step 4 and 5 of the GINA guidelines. And these patients often are very symptomatic, but it's important for us to exclude alternative diagnoses and comorbidities that have to be treated, as well as avoid trigger factors if possible. So the ATS workshop criteria for severe asthma have this following criteria, and patients with severe asthma must satisfy 2 major criteria, where they have continuous or near continuous oral corticosteroid prescriptions, as well as the need for high dose inhaled corticosteroids. Or they may have 1 major criteria and 2 minor criteria where they need SABA on a regular basis, or they may have had a near fatal asthma event in the past. So as we can see, the severe refractory asthma requires high dose inhaled corticosteroids, and they usually have a combination therapy. And despite optimization of these medical treatments, as well as inhaler technique and avoidance of allergens and treatment of comorbidities, they remain symptomatic. And the prevalence of severe asthma really is between 5 to 10%, and of which the severe asthma category, 4 out of 10 patients remain symptomatic. So in this slide, this is very important because we have different classification of patients, what we perceive as severe asthma, but really they may not be really treatment-resistant severe asthma. They may be untreated severe asthma where we need to address healthcare and medication access, non-adherence, as well as making sure that they are using the device appropriately. Smoking cessation needs to be advised, as well as avoidance of allergens such as occupational, environmental, or even medications that they are put on. It is also important to manage comorbidities that can exacerbate asthma, such as rhinosinusitis, gastric reflux, obesity, or obstructive sleep apnea, because these patients may be awakened in the middle of the night thinking that they have a severe asthma attack, but really they are suffering from obstructive sleep apnea. So after excluding these categories, the real treatment-resistant severe asthma, where we need novel therapies such as biologics and bronchial thermoplasty, really occurs only about 5 to 10%, and of which within this category, only about 4 out of 10 remain symptomatic, requiring biologics and bronchial thermoplasty. And when we biopsy patients with very severe asthma, you can see that there's a lot of airway inflammation as compared to controls. And in this histology, a bar plot, it actually shows that prominent smooth muscle is prominently featured in the biopsy specimens, as well as submucosal eosinophilic airway inflammation. And smooth muscles may play a very important role in an asthmatic airway because not only it is the end organ that causes bronchoconstriction, hyperresponsiveness, it may also promote inflammation by secreting all these inflammatory and angiogenic factors that promotes the vicious cycle. And currently, there are only these medications that target the airway smooth muscles, such as the beta-2 agonists, glucocorticoids, as well as omalizumab. And bronchial thermoplasty is a novel bronchoscopic technique that really only targets the smooth muscle, and hence it reduces bronchoconstriction, and with that reduces the asthma exacerbations and improve the quality of life. And in this canine model where the biopsies were done after the dog is sacrificed, you can see that the smooth muscle following bronchial thermoplasty is replaced by fibrosis. And importantly, the epithelium is regrown. Bronchial thermoplasty, although it is a heat treatment, it does not change the ciliated epithelium. So bronchial thermoplasty requires putting this array into the bronchoscope. And what it does is to treat 3 to 10 millimeters airway sequentially. And heat or the radio frequency energy is applied along the contact points of the metal array. And with 65 degrees centigrade, it really just targets the smooth muscle, and there is no permanent damage to the airway epithelium. Therefore, it reduces the airway smooth muscle and decreases the bronchoconstriction. The only contraindication is in somebody with a pacemaker, where we are not sure whether the radiofrequency ablation or the energy could affect the pacemaker. However, it is important to note that this is a complementary treatment. It does not aim to replace inhaled corticosteroids, which is the cornerstone of asthma treatment. So how is it done? We usually start with the right lower lobe, all the segments that are in the right lower lobe, and sparing the middle lobe, because we are not sure about, in the early times, we were not sure whether it causes bronchostricture and hence the middle lobe syndrome. And we allow the patient to heal or recover for a period of 3 weeks, and that will follow with the left lower lobe. and then 3 weeks later, both upper lobes. So this is how we do bronchothermoplasty over 3 treatments. And bronchothermoplasty have a lot of clinical studies that show its efficacy, and the pivotal study is really the AIR2 trial, which is a sham-controlled double-blind study where they recruited 297 patients who are on high inhaled corticosteroids as well as combination therapy. What they looked at was the improvement in AQ, LQ, as well as what they found clinical improved outcomes, or 32% reduction in severe exacerbations, as well as 84% reduction in the ER visits, and 73% reduction in hospitalization for asthma, and resulting in 66% less days lost from work, school, and other activities. There were also no device-related adverse events or deaths, hence assuring its safety profile. So studies like the RESET-2 trial also looks at the bronchothermoplasty effect at 2 years, and what they found that the decrease in exacerbations persisted up to 2 years and then up to 5 years. So 5 years, they have repeated CT scans at 2 and 5 years, looking specifically for structural changes such as strictures or bronchiectasis, and none were found. And again, it showed at 5 years sustained reduction in asthma attacks and the ER visits. Hence, the conclusion from the authors was that unlike current available therapies with short-term effect, a single BT treatment comprising of 3 procedures actually provides long-term benefit that can lead to long-term savings. So interestingly, BT has always been touted to be effective for non-allergic patients. And in the AIR2 trial with 5 years of follow-up, we found that BT is effective in both the allergic and non-allergic patients, meaning the Th2 high and the Th2 low patients. And just 2 years ago, we have had the 10-year study, safety study from the AIR2 trial, where they followed these patients up for a median of 12 years. And again, the reductions in severe exacerbations resulting in hospitalizations, unscheduled ER visits, as well as physician visits, they were sustained, and good quality of life measurements as well. Spirometry did not differ or decline as a result of BT. However, 5 patients were found out of the 892 patients had mild bronchiectasis, 5 had mild bronchiectasis, and 1 had moderate bronchiectasis. And this was also mirrored by Chup et al. Published in CHEST 2022, where they had a multi-center prospective trial recruiting 284 patients with severe asthma. And what they found was also mirroring the AIR2 trial and the 10-year study trial, where the hospitalizations and severe exacerbations were correspondingly decreased over a period of 5 years. And this is a very interesting study that was published in 2023, where it's really a real-world practice, where they looked at patients receiving continuous oral corticosteroid treatment as well as biologics. So in this study, where they used a self-controlled case series study, 71% of them had required continuous oral corticosteroid therapy, and 44% received biologics. And what they found was that BT in this group of patients with very severe refractory asthma actually led to a reduction in hospital admission as well as ER visits. What about procedural safety? It was criticized that BT is not in the guidelines because it is associated with harms, and this is usually seen within the week of the procedure. Okay, none of them could not be reversed, and this usually resolved in the first day, actually following the bronchothermoplasty treatment. So what about activations? In this study published by the Australian group, for which Elvin is part of it, they found that if patients receive more activations, up to 200 activations, it actually gives a better improvement in the quality of life scores than someone who receives less than that. So they found a threshold number to be about 140 activations over 3 procedures. The worry is that we are administering radio frequency energy in the airways. So if we increase the number of activations, does it cause severe adverse events? So in this study, it actually shows that there may be a transient decrease in FEV1 and FEV1% from baseline, but the number of radio frequency activations is not associated with serious adverse events. Okay? There may be also acute radiological abnormalities following bronchosomoplasty, where they did a chest X-ray followed by ultra-low dose CT within 5 hours of the procedure. And what they found was there may be peribronchial atelectasis or peribronchial consolidation and ground glass infiltrates immediately following bronchosomoplasty. However, these would resolve completely following the procedure within 2 weeks and without any serious sequelae. Okay, one patient actually just had a focal dilatation of the airway. So we did a meta-analysis comparing bronchosomoplasty with biologics, and we used a network meta-analysis process where we looked at all the severe asthma trials using biologics versus bronchosomoplasty. And what we found that bronchosomoplasty was non-inferior to biologics. And what I'm going to show you is that bronchosomoplasty is the only intervention that really reverses the airway remodeling or looks at the airway remodeling. So what happens was that this patient before bronchosomoplasty had bronchial biopsy and followed by another biopsy about 3 months later. And what you can see that the pink area, which is smooth muscle, has completely been replaced by collagen, and hence there is obvious reduction in the smooth muscle mass. And this is also corroborated from the confocal study, where this top panel actually shows that this is a non-responder. Initially, the smooth muscle decreases, but after a year or two, it actually regrows back. And this is a patient who has responded well, where the smooth muscle layer is ablated and decreased, and this is sustained up to 2 years. So we also did our own study where we tried to phenotype, we tried to characterize the phenotypes. And suffice to say that we have a significant number of patients who belong to the eosinophilic or Th2 high subtype, up to 62%. And these patients, we subject them to radial EBUS measurements every time when they go for bronchosomoplasty. And what we found was that the wall of the airways actually decreases almost immedately following the first procedure. We can see that the airway wall thickness, it's reduced from 2.6 millimeters to at the end of the bronchosomoplasty, which was 6 weeks later. This was the right RB8, where it shows that it's nearly normal at 1.4 millimeters. This was also corroborated with endobronchial biopsies separated 1 year apart, so that the previous biopsy site, people have criticized that if you biopsy sequentially over the same site, you may actually be debulking the smooth muscle. So what we did was to biopsy the area first before bronchosomoplasty, followed by 1 year later. As you can see, the brown areas, which are muscle, okay, is actually decreased in the muscle mass. So this is our study showing that there are some who initially respond, but then the smooth muscle grows back. And one of which patients was actually having a diffuse panbronchiolitis. So this was this is a patient that we shouldn't have done, while this other patient continued to have allergen exposure. He keeps 17 cats. And although I managed to advised him to cut down the number of cats from 17 to 4. He still had 4, and he had a very emotional attachment with these 4 cats. So he's unable to get rid of them. So you can see again, the smooth muscle, which is stained brown, has decreased in mass 1 year later on the same biopsy site. So there is some research looking at non-invasive imaging. So perhaps hyperpolarized gas MRI can assess the functional alterations of airways within the lungs, because persistence to this airway remodeling can affect the alterations in airflow, and perhaps this can be a potential imaging modality to guide localized or repeat treatments. So with that, thank you so much for your attention.
Well, thanks, Dr. Lee and Dr. Ng. This is a really a wide-reaching set of presentations. We have a minute, hopefully, I think about a minute left, and there's a couple of questions I think the audience would be interested in. Dr. Blesaroglu actually asked Dr. Ng, with all the different modalities of therapies, is there any role, well, number one, what's the duration of efficacy, if you could speak to any one of those, and if a person's has a good result, but then that wanes, can they be retreated in any form of those modalities?
Thanks, Carla. So the best evidence is for valves because there's so many RCTs and long-term follow-up. And the answer is that generally endobronchial valves, if you get volume loss, which is in about 80% of patients, then there's improvement in prognosis, improvement in survival, improvement in symptoms. But lung function declines as it does with everyone with age and also with a past smoking history. So effectively what you're doing is you're basically not allowing, but the decline occurs from a higher baseline. So you're giving them 2, 3, 4 years of improved symptoms before they reach what they were like at the time you did the endobronchial valves. So that's variable, depends on the amount of volume loss, but it can be anywhere from 2 to 4 years. But lung function does decline slowly, as it does with all patients with COPD. Regarding retreatment, there's not many cases of repeat lobar valve patients. There are a number of reports of bilateral sequential valves, but that's anecdotal. I think in the future, segmental therapy allows itself to be much more appropriate for subsequent therapy and consequential therapy rather than single therapy. But that's there's not evidence for that, but it makes sense that segmental therapy would be more suited for subsequent therapy. So, Carla, there was a question for you as well on the questions, looking at should you be doing biopsies for non-IPF patients? You're just muted at the moment, I'm sorry.
I'm trying to unmute myself. Thank you. Yeah, I think the answer to the question is, I think, what we're finding is that with, UIP or IPF can now be more readily diagnosed with the imaging. But I think anything else, like fibrotic NSIP, all the other ILDs that are non-IPF, I think we are moving to a definitive diagnosis in a lot of these patients if they're younger and also have, they have evolution of symptoms. So I think the answer is we're evolving to doing that, yes. And then I saw one other question for Pyng, if I can take the liberty. The question was, if thermoplasty is non-inferior to biologics in treatment for resistant severe persistent asthma, why is it not on the market any longer?
Yeah, it is very sad. So both me and Alvin are really upset about this because we have our patients who really respond to bronchial thermoplasty, but because of reimbursement issues, especially in the US as well as in Europe, Boston Scientific has decided not to manufacture any more of their catheters or to submit the bronchothermoplasty machine for FDA approval. I think they need to do it every 10 years. So it's about time. So that's the reason why it is no longer available in the market.
Yeah.
Hopefully, some Chinese company may take it up, hopefully.
Wonderful. Well, thanks again to this wonderful panel. I certainly have enjoyed all your presentations, and thanks for the audience for your questions. And with that, we will transition the program to our next group. Dr. Ali, I believe, is getting ready for roundtable discussion after a little break. Thank you.
Michael, can you hear me?
Yes, I can hear you.
Okay, I'm gonna
We heard you, Ali, but your audio is cutting out.
okay, so you can hear me much better now, I guess, because I'm on my phone. Okay, so I'm gonna use both. Let me know when to start my session.
Whenever you're ready. Thank you.
Okay. Can I share? Can I share my slides?
Please, yes.
Do you see my screen?
Yes, we can see your screen.
You can see my slides, correct?
Yes. Is advisable to go to full screen mode or presentation mode?
Better?
Thank you. Perfect.
Well, thank you, everybody. Welcome to the last session. My name is Ali Musani. I am an interventional pulmonologist from USA. And this session is to do a roundtable discussion. I see that I'm going to try and see if I can switch the screen to see if I have the panelists before I completely switch the screen. So I guess once I do that, just bear with me for a second, please. I'm just trying to see. Okay. Oh. Anyways, looks like I have lost. You can hear me still, right? Can you all hear me?
Yes, Ali.
Okay, perfect. Okay. So thank you very much again for joining us. We have a panel discussion, and topic is how to overcome costs and access to technology, training and expertise. Primarily, probably the most complex topic in the context of WABIP and interventional pulmonology, how to teach, train, and set up interventional pulmonology programs around the world, and contain the cost. We had another discussion on this yesterday roundtable, which was chaired by Levent. Excuse me, and he discussed about some of the challenges in cost containing when technologies are developed in the most developed countries, rich countries, and then when they need to be disseminated to the developing countries. Our panel of experts includes Dr. Felix Hertz from Germany, Dr. Sevas Kozov from Russia, Dr. Hind Jena from Morocco, Dr. Antonio Bugalu from Portugal, Dr. Popevic from Serbia, and Dr. VR Pathabi from Rahman from India, and there is a Tunisia Society chair, but there is no name for that person. So are you all, so as I had requested to all of you that we will go ahead and have a discussion of 5 minutes each from all the discussants about the issues that are raised in this roundtable, which is how to spread technology and training and contain cost. So I thought we would focus on training and technology transfer, but predominantly teaching, training, and dissemination of knowledge. But we will definitely talk about other issues too, partly because there was an extensive discussion over an hour yesterday on, as I mentioned, technology development and transfer to developing countries. To elucidate my point, I will give you a brief 10-15-minute discussion on the first Interventional Pulmonology Institute of the World Association of Bronchology, which was established in 2023, and the first session started in October. I'll give you a brief background and get you an idea of what WABIP is doing to disseminate the knowledge of IP and develop expertise throughout the world. So, okay, now I know what is going on, partly. Okay, so the philosophy of this my picture keeps coming in the middle. Okay, whatever. The philosophy of this institute, it was that to have a center somewhere in the world where we could bring the fellows from all over the world, pulmonologists, and train them into interventional pulmonology, and then send them back to their countries where they can then develop centers and teach and train. But obviously, as you know, there are huge limitations in that. We have fellowships in the US and Europe, but these are limited fellowships. There are only few people who can get into them. In order to get into American fellowships, which are the largest training programs in the world, you have to be a doctor in America. You should have done your residency and fellowships, which is not possible for millions of people around the world. So we had to develop a program where it can be done for, excuse me, for everybody. So basically, we needed to, in plain terms, democratize the knowledge of medicine beyond geographic, religious, or ethnic borders. So the plan was that WABIP will collaborate with some public or private institutions around the world. This would be a partnership where the institution will provide us with some of the infrastructure, such as hospital, patients, clinics, and then WABIP will provide the training, teachers, curriculum, training methodology, testing, and eventually certification. And then with this whole process, we will bring people with a very stringent selection criteria from all over the world. No specific national or international training was required as long as you were a pulmonologist in your own country or a thoracic surgeon in your own country. And then in the process, we'll do two more things. One was to provide health services in the country where we are training, because we are using their resources, and they should get something in return since we're not reimbursing them for their facilities or their time. And number two, once the people are trained, when they go back, we help them develop programs in their own countries so they can provide clinical services and train local people in their countries. So around 5 years before 2023 October, I started talking to different countries as to how to establish this. Some of the countries that I worked got sometimes very close to were Malaysia, which came the closest, where the last step was kind of stopped by the government because they wouldn't allow us to touch their patients, but we were very close there. But we did explore India and Egypt, and eventually in Turkey, we were able to establish this program. We have a very robust structure from fellow selection to teaching, training, curriculum, testing, and we have international committees for everything. It's a very transparent, very open concept. The fellowship committee that we put together has all these committees, and you see some of the members here who were initially involved in the first of these committees. As I mentioned earlier, the goal was to develop a program where we can start programs in the country, train people, then send these people back to their own countries, where they will then train, teach, start new programs, and then as a result, generate or train and teach their own junior faculty. Okay, I have obviously this circle of death. Must be something with my laptop. You guys see this little circle? Can you guys hear me?
Yes, we can hear you,
Yes.
but we
Yes.
cannot see your circle.
Like
You cannot
frozen.
see our slides?
No, it's a frozen slide. The trickle-down effect.
Yeah, so I don't know what happened. Yeah, so I'm trying to move my slide and it's not moving. Anyways, so I can continue talking. So we started this program. We have a committee. In 2023, we started the first fellow. It's a quarterly training program, which is where fellows are selected from all over the world. After the first quarter for 2024, we had 60 applicants from 20 different countries. We only take fellows from developing countries, so we don't take any fellows from developed countries like USA, Canada, and most of the Western European countries, because they have their own resources, they have their own programs. I don't know what's going on with my computer. Anyways, I am still, excuse me. So the quarterly program then trains. I'm going to disconnect from my laptop and reconnect with my phone. You guys can still, I guess, see me and hear me, correct?
Correct.
Okay. So this is a quarterly program, and fellowship is mostly done in Turkey, but we do have a initial simulation training, which is done either in Florence, Italy, by Lorenzo Corbetta, or in Athens by our Greek experts. And then they go to Istanbul, where they go for 2.5-month training. It used to be a single center training, but now it has been expanded to a multi-center training, which includes Ankara, Eskişehir, and several hospitals in Istanbul, where they're all trained in different techniques. Some hospitals are cancer centers, so they get really good training in rigid bronchoscopy and EBUS. Other centers are more private hospitals where they learn several other techniques like general bronchoscopy, basic bronchoscopies, and other techniques like navigation bronchoscopy. So after 3 months of training, there is usually a exam which allows them to, which is usually conducted by at least 2 local faculties and 1 international faculty. We want to make sure this is a very transparent program and transparent system, so we always bring 1 international faculty there. After the examination, if they pass the examination, they are given certificates, which are then proof that they can go to their respective countries and start training. First of all, start practicing more for themselves, and then after that, if once they feel comfortable, they can start their own programs and start teaching people. We have had 40 applicants in the 2025 program, which 20 applicants from 20 countries and 60 applicants from 20 countries. Okay, I'm gonna hang on just a second, please. Do you see my slides?
Yes, sir.
Yes. Yeah, we see them.
Perfect.
Now it's better, Ali. I think if you're on your PC, it works much better than your phone.
No, I'm not on my phone. This is my laptop.
Yeah, so it works better now.
Okay. Well, the slides cannot be done from my phone. Anyways. Okay. I'm giving up on you guys can hear me, correct?
Yes.
Okay. So after the training, we have sent people back to their countries to start their own programs. I had some wonderful slides to show you that in 2025, we had 175 applicants from 44 countries, and most of those countries were developing countries. And then we also then I had another slide showing you how our people have gone and developed amazing programs in their own countries. So one of the bright examples of that was, well, many examples. So one of our trainees in India and at one of the largest programs in the country called AIMS. There are many programs, but AIMS is a pretty popular place in India. And in Rishikesh, she was one of our first fellows, Ruchi Dua. She has started a good program there, which working with their current chief of pulmonary, who's also doing a great work there. Sean Nestorp is a fellow of ours who did an amazing training program. He's running a program and serving people in South Africa. Similarly, we have program in by our colleague in Iraq. He is very popular. He's doing EBUS courses, training people, and he's on social media all the time. So we have about 5 or 6 really significant programs that people have started in their countries and training. So this is sort of our model of teaching and training and developing programs in the countries, different countries. AIBIP has really taken the lead in this, and this is the first of its kind model in the world where we can teach and train people from developing countries and send them back to their countries. We are also trying to provide some resources to whatever is in our control to help them develop their own programs, and whatever we can do in terms of guiding them. So even when they're back in their own countries, they are constantly in contact with us. We have a session, a whole program on the social media where we connect regularly with each other and help each other with difficult situations. We were able to send them some devices in few places. One of the important one was Sudan, where we were able to send some rigid bronchoscopes. We also sent some technology to the training center in Istanbul, where we have rigidoscope, which our fellows are using in training, and some needles. I also want to, whether slides show or not, I also want to mention that we are very thankful to Olympus USA, which is really one of the most ardent supporters of our program. They have, from the very first day, from the inception of this program, they have been helping us financially, and they are providing us devices too. So they have provided us needles and other devices for our training programs, because you can imagine when we have 3 or 4 people training on a daily basis in multiple centers, we are consuming a lot of disposables and also using the scopes. So that's pretty much it. I'm sorry, my slides didn't work. Do you see this slide? You do. So this is, I'm just not going to go into the mode where, and you can see me and hear me, correct? I see somebody nodding. Yes,
Correct.
no?
Yes.
So, so this is the slide which this is these are some of our fellows. This is Diego Paul Vega from Ecuador, from India, from Bolivia, South Africa, Iraq, Malaysia, India, Libya. These fellows have done amazing jobs in their own countries. They have developed programs. These are some of the pictures of our training. You can see Dr. Levent Dalar teaching people. This is our Diego, our fellow learning. This is a picture of a simulation training in Greece and Athens, and in Italy. These are our local faculty. They really are the ones who are doing the most amazing job of training people. They are from all over Turkey. Semra, I see your hand. I'll get to you in a second. I'm sorry. This is our weekly lecture program, which is sponsored by, these lectures are given by the international faculty. You can see the flags of different countries. These are different people who give lectures on a weekly basis from all over the world. And then again, this is a final certification exam. You can see Dr. Gasparini examining Sean and Melvi, our two applicants, Sean from South Africa, Melvi's from Bolivia, and then Dr. Okay, I'm blanking on his name. Lorenzo Corbetta is also teaching Ruchi Dua how to do simulation bronchoscopy. This is after the certification exam. People get their certificates, which they can go and show to their country. These are some of the centers where they train and they are with their patients. This was, as I mentioned, 20 countries, 68 fellows in 2025. But now in 2026, you can see our numbers have gone skyrocketed from 175 applicants from 44 countries for 10 sites. These are all the people who are amazing, doing amazing jobs. Melvi is vice president of the Bolivia Respiratory Society. Jane is the president of the Ghana Thoracic Society. Ruchi is the training program director for IP. Hadi is doing an amazing job in Iraq, and Sean is doing a great job in South Africa in teaching and training. So these are our fellowship committees. Selection committee chair is Javier from Spain. Levent is the chair of the director of the local site. Lorenzo is the curriculum director. I oversee the entire program. And these are our local faculty. So I will now stop. I'm sorry, sorry for all the troubles from my computer. In the end, what we're trying to do is justice. We want to go beyond equality and equity. We want to go to justice, where the systems is designed to help everyone without having to do any specific favors to anybody. Give them a level playing field and let them show their strengths and their qualities without propping them up on stools or without giving them handouts. Thank you very much. I'll open it up for discussion. I think Semra has her hand up. So Semra, please go ahead. Semra? Okay. I will open. So let's start with our panelists. I see Hind, Jenna. Please go ahead, unmute yourself and tell us what do you think and how can we resolve these issues of international training, cost containment, and dissemination of knowledge. We can't hear you. You're muted.
Okay, now it's good. You can hear me.
Yes, we can hear you.
Hi, Professor Hussein. Good morning. I'm truly honored to take part in this wonderful experience alongside my mentors and colleagues. You know, this topic, it's very close to my heart because access to quality healthcare is not luxury. It's fundamental right. Yet in interventional pulmonology, we continue to see significant inequalities in access to both training and technology, especially in countries where the discipline is still at an early stage of development. Let's start by training. You know, in many regions, opportunity remain limited and often depend on individual initiative. Physicians must personally cover the cost of courses, travel, and accommodations. for those in private practice, this can mean closing their clinics for several days or months with financial losses and risks to their professional stability. And secondly, as you know, the gap between theory and practice, it's big. While theoretical courses and simulation training are indispensable, there can't be real clinical experience. Too often, young doctors don't have the chance to be guided during their first procedures, which slow their progress and hinder the wider spread of our discipline. Finally, the technological and financial disparities. Advanced tools such as ABUS, cryotherapy, Airway Stents, or are still concentrated in a few major centers of high-income countries. According to the WHO, more than 50% of low and middle-income countries lack access to essential medical technologies. And the Lancet Commission on Global Surgery reminds us that 5 billion people worldwide still don't have access to safe and affordable surgical and interventional techniques. So how do we move forward? I believe progress requires and stepwise and coordinate strategy. First of all, we have to build strong training foundations, develop reference centers in each country. And as you know, each country has its own context and resources. But we can have centers, the centers can be like university hospitals. It can be a public-private initiative or private institutions. That matters most is that they are inclusive, serve as true meaning hubs, and ensure access for all patients. I think we have to adopt hybrid training models by combining online education with regional simulation hubs that can reduce in costs and bring education closer to doctors. We can introduce stepwise certification system, moving progressively from theory to simulation to supervise practice, ensuring quality and recognition. We have to ensure practical learning and membership, establish mentorship and membership program, so younger doctors are guided during their first real procedure and supported through training initiatives. Implement train programs, preparing local experts who can multiply knowledge transfer and strong progress. Expand access through collaboration. I believe that strong relation and international partnership to provide scholarships, exchanges, and sustainable collaboration for young physicians. Create relation knowledge sharing networks for real-time extension for protocols, clinical cases, and expertise. And we can use the telemedicine and teleprotecting loaning international experts to remotely supervise procedures and provide support for young doctors. Concerning the financial and technological barriers, I think we have to negotiate collectively for lower prices and equipment and consumables, making advanced technology more accessible. We have to work closely with industry and manufacturer to provide affordable training kits. And we have to establish dedicated funding schemes for young physicians and private doctors supported by association and international organization like like IP, WABIP IP. And of course, I don't know if this is the same problem in other countries, but we have a big problem in Morocco. The health authorities don't recognize interventional pulmonary as a public health priority yet, and we had to ensure integration of procedures into national health insurance system, reducing financial burden to patients and doctors. And I think this is shared responsibility of both local association and international societies to amplify the voice of the community. I think that we can't allow access to interventional pulmonology to depend solely in personal sacrifice. Training, mentorship, technology, and advocacy must be structured, supported, and equitable. Together, we carry the responsibility to transform the access into a right and not a privilege.
Great, thank you very much. This is very true. I completely agree with you that that health and education are not a privilege. It's a right of every citizen in every country. Who wants to go next and express their views? On my left on top is Dr. Sivakozov. I'm sorry if I'm pronouncing your name wrong. I apologize.
Oh, you're completely right. You're completely doing this right. Okay, just can I share slides for 3 minutes?
Yes.
Is it possible?
Please.
Okay, I'll do my best. But sorry for that. I'm just trying to do this one. So it's possible.
If you done the share, yeah, there we go. You have it.
Yeah, okay.
Now you're
And,
sharing. Yeah, you see your slides.
Yeah, thank you. So can you see it open in a full scale? Yeah, okay.
Yes.
Yes.
So yeah, Russia is completely different from any other world's countries because we're always in struggle with bronchoscopy, despite the huge population. We have 11 time zones, and we get largest sanctions ever. So that means that we have no any access to new tools like robots, ablation, navigation, mobile cone beam, and a limited access to the navigation and the cryo. And I will make several steps how we're trying to avoid and to override the gap between the level of equipment we got in real life in Russia and in the rest of the world. Another point is the bronchoscopy in our country is completely crazy looking for the colleagues from Western Europe and United States because this bronchoscopy is a part of endoscopy, not respiratory care. This is a scope-oriented approach, not the approach for clinical point. This is historically driven. We're trying to change it, but still we're struggling. And no success on changing this idea. So most of our newcomers in the field, they come from the general endoscopy, so they need to perform both GI procedures and respiratory procedures. That means that we got a lack of expertise and a lack of training due to the huge programs for GI endoscopy, and this is quite good level on an international level also, but for the bronchoscopy, it's quite problematic. And when we are talking to our newcomers in the field and trying to do all of our best and to teach them how to go with the navigation, for example. So we're trying to teach them that they need to use their own intelligence. Even if you live in a country with a limited access to the new technology, you still got your own. your natural interest. So the manual branching, free VBN, and the slim scopes and the USB. For example, like here, if you have an R6 peripheral nodule, you can go with a transesophageal approach with the eboscope and find the lesion and make a biopsy. So dressed to be a 7 of technology, not a 7, and use our best practice. We're still trying to do our homework and to use the conventional techniques. So the new technologies from mediastinum and cryo, we always teach that in a bronchoscopy, you always have a nice ability to step back. Like here, you can see on the slide the cryo, but nobody has much access to the cryo now in Russia, especially in the field of EBIS. And still, the conventional turbine is useful, and the rigid turbine is cheaper. And you see here, there's a true cut needle, and it's better than cryo because we use the 16 gauge true cut needles. For interstitial lung diseases, again, we're trying to provide the best options from 90s because the BAL, TBLB, and endobronchial biopsy are still in the game, and they're accessible and affordable for both patients and doctors. So, and the main idea for today's meeting is the bridging the gap in expertise and training. So I'll just try to focus on personal experience with those who are really coming to this area. At first, you will never reach a success if you will not be passionate about your work. So you got to know your homework. You got to know the basics of bronchoscopy, basics of clinical things, because we are not operators. We are doctors at first. So it's really important to find our mentor. The first mentor when I was found, it was in 2005, 20 years ago in Schillerhöhe in Germany. So I still remember my first professor who was really preparing me for the bronchoscopies. So you got to create your local team when you come back, network with your national teammates, and seek industry support. And that's why, for example, now in Russia, we have several supported by different companies, training centers and training programs. But again, the main issue is how can you implement all the steps, starting from seeking a new generation, to those people who are really interested. Because if you will not be interested in this subspecialty, then probably nobody will invest in you. And again, last but not the least, reaching the peak, race to the next generation. Like here, one of our young doctors is now becoming a new star. And the main thing in our work is to do our best and let the rest. And I hope that tomorrow we will have the first chance to train Russian doctors in abroad. We have made a choice to the Serbia, and I hope that for our next training, the Professor Spasoje Popevic will share some details. Sorry if I was a bit out of the scope for the exact meeting, but I wanted to share our own experience in the field.
Well, I would love to see some of the applicants from Russia in our IPI program next year. So application is on the website of the WABIP, and we actually try to support financially to our fellows. I forgot to mention that our fellowship is supported financially, at least until now. We give them somewhere between 2 to 3, and trying to give $4,000 for 3-month rotation. And I also forgot to mention that besides Olympus, we had a couple other companies who helped us. VA-Thin was a flexible disposable bronchoscope people. They initially supported us a lot. And individual people, Dr. Mehta has given us a grant to sponsor a fellow. Dr. Levent Dalar has given us largest single donation by a person, not by industry. So far, he has really given us a very large donation of his entire stipend for the whole year by the IPI. He donated the whole stipend to sponsor 2 fellows from developing countries. And then our friends from Europe have also given us money. So number 1, we do provide financial support. Number 2, if any of you or your institutions would like to support us by instruments or by money. So if you move from one hospital to other and you have some research funding left, So Dr. Kayed from Essen, who now is in, I think, some other country in some other city from Europe, he was moving from one hospital to other. He had some leftover money in his research fund, which he couldn't take to the other hospital. He gave it to us. So if you have money, you have any instruments, your hospital is retiring any devices, let us know. Anyways, so I see two more people, Antonio and Spasoje. Who wants to go first? Take it away. We have about 15 minutes total left.
Spasoje, do you want to talk?
Thank you. Yes, or you, whatever you think. Okay, maybe because just to make a connection with what Dr. Sivokosov told you. In Serbia, actually, we were once a center for former Yugoslavia for teaching bronchoscopy, and bronchoscopy is really in clinical center of Serbia where we work. We practically trained the majority of bronchoscopies, not just in Serbia, in neighboring countries, but also from all over the world. Actually, from the 1990s, we have a school of bronchoscopy on different levels, from the basic bronchoscopy skills to the so-called basic bronchoscopy skills to advanced interventional pulmonology procedures. And actually, we recognize, Dr. Sivokosov and me, we recognize the need for things that are for methods that are not accessible in Russia, and but also to give a structured educational program we have in Serbia for any level of bronchoscopy and interventional pulmonology procedures. So we decided to provide the training for cryotechnologies in interventional pulmonology starting tomorrow. There are a lot of things that we plan to do, but just a hint. In Serbia, we have a unique opportunity that a lot of countries can come to us without visa. That's one thing. Second thing is that we work in a high volume center like in University Clinical Center of Serbia. We do around 8,000 bronchoscopies per year. Out of those, maybe 350 to 400 rigid bronchoscopies. And the third thing is that we have with Russia agreement that our medical licenses are mutually recognized. So in Serbia, under observation, they will be there is going to be a possibility to work on patients, of course, after we assess carefully their level of knowledge, after they pass the models, simulators, then we go from there to see how it will work on patients. Actually, there is one more thing I would like to add. When I have a lot of experience in establishing interventional pulmonology units, and I can tell you one thing. You give them education, they go to their respective hospitals, and if they don't apply what they learned, your education, your time is wasted. My suggestion is not to help them just with instruments and knowledge. Go there, help them with their first patient, with their second, 10th patient. Spend some time, help them to establish their interventional pulmonology unit. I did that in Serbia, in some local hospitals, and in some hospitals where I didn't go, that knowledge just they just dropped out of bronchoscopy. They lost their competency because they were not doing enough. And in hospitals where we support them all the time, when they can consult us on any difficult case, when we go there to help them, actually there is a progress, and there is no reason that we cannot help people around the world just to help them establish on-site their interventional pulmonology units. Otherwise, you have like a 1-year fellowship, you are stuck with a candidate who is not going to do that in the future, and you are wasting your time. So I am for more proactive approach, train them and then go with them, help them make their first steps. These are my thoughts on the matter. Thank you.
Great. Thank you very much. And I completely agree with you. We used to do that for developing smaller programs. And we would love to continue to do that with our IPI centers. Sometimes the traveling part and going and spending time becomes very difficult, but both Levent and I offer all our fellows that we are happy to come and train you. And equally important is to provide them with devices, continued mentorship. We ask all of them to become WABIP members, come to our national meetings where we sit down with them and spend significant time talking about how their programs are doing, what are their limitations, what else we can do to help them. Anyways, Antonio, what are your thoughts?
Hi everyone. It's a pleasure and an honor to be here. I think we are discussing a couple of very important things, and I think that we are discussing two things. One is how to train the future generations of IP in middle and low-income countries, especially, and also how we can set for the next technology boom in our own units and in our own countries. And we heard Ilya talking about his difficulties in Russia, but I'm sure that Hindjana and even Spasoje, we cannot afford robotic bronchoscopy, or we cannot afford some of the new technology that most companies are promoting. And so I think the key idea here is that not all technologies are equally transformative. So I think we have to focus first on the ones who have the biggest impact on our patients, on survival, quality of life, and also cost savings. So if you have limited funds, we are not going to allocate those funds to robotic bronchoscopy. And so we have to choose wisely, and we have to have a technology ladder. And so maybe we start with basic bronchoscopy, chest ultrasound, thoracocentesis, and then we move to rigid bronchoscopy, EBUS, fluoroscopy, cryo, and then at the end, valves, thermoplasty, and robotic bronchoscopy. But as I'm working in Lisbon, Portugal, and as we are not a low, not a high, a medium income country, so we have, I would say, national centers, and we have certain centers that have some of this technology, like cone beam and other technology, but these are very specific centers like cancer centers, and so we refer some of these patients to these specific centers. Of course, we know that every bronchoscopy unit, every hospital, everyone wants to have everything. We have to have the latest technology, but we have limited resources, and so we have to choose wisely. Another thing that we're talking about is how to train people and how to train our own residents and fellows, and how to train what we call low-income countries. And so we have here in Portugal, we have every fellow has like 6 months training of standard bronchoscopy, and then if they want to proceed with their further study and further improve themselves, they can either choose a reference unit here in Portugal, or they can try to raise money and funds to go elsewhere. And there are ERS courses, ABIP courses, and so everyone is trying to do their own pathway in IP. Another important thing is that the Portuguese Pulmonology Society has a very important link to low-income countries that are Portuguese speaking native countries also. And so we have also a joint venture with Angola and Mozambique and Cape Verde, for instance. And we are starting to create also programs of telementoring and sharing IP procedures and going to their congresses. And then we have joint congresses also and joint workshops in order to train the future generations of some of these low-income countries. So I think what we're discussing here is very, very, very important. We are discussing costs, we are discussing synergies between countries, and we know that for everywhere the access to IP is not all about equal technology and opportunities in the world, and we know that for sure. But I think it's about the right tool for the right patient at the right time. And I think we have to focus training the next generations and doing the best for our patients.
Great. Thank you very much. This is exactly what I think every country should do to, I agree with you, to stay in their finite resources and try to grow as best as they can and have a very thoughtful strategy on where to spend their resources. Your country or some other countries may benefit a lot more with having e-bronchoscopes or rigid bronchoscopes or pleuroscopes than having a robotic bronchoscopy or cone beam CT. In the price of a one cone beam and one robotic, you could probably have 15 rigid bronchoscopes or 3 or 4 or 5 e-bronchoscopes, which has shown to reduce the cost of healthcare by preventing mediastinoscopies and surgeries and allows you to diagnose and stage cancers. That's very true.
Mm-hmm.
Any other comments from anybody else? I see 2 more people on my panel. One is Dr. Rahman from India. I don't see him. That's not Pratibha, is it? Hind? You're muted. This is not Pratibha. Pratibha is not Rahman. Her last name is not Rahman,
No,
right?
this is it's a guy. It's not
Okay, Patabi Rahman, and then the last person is Tunisian Society Chair, but they're not here either, I guess.
Yeah, I think you're right.
Okay. So any other comments, any other discussion points before we close in the next few minutes? Oh, I see Algeria is here. Okay, so go ahead and if you want to, are you the chair of the Tunisian Society? If you are, please go ahead and speak up. Okay. Any questions? I am looking at do you guys see any questions in the chat room?
I have a question.
Sure, go ahead.
So all of the educators on the board, I'm just wondering whether is there anything that WABIP can help with regards to the training? Would something standardization or some protocols or some, to kind of minimize the variability? I think sometimes, even in inspection bronchoscopy, we often find there is a wide variability with regards to skill acquisition or the teaching or something like that. Or what do you think might be helpful? I mean, I'm just wondering. Like book resources for some fellowship program or something like that, or what, so that we can kind of scale up really quickly. I think the most important is really inspection bronchoscopy because that sets the foundation for all the advanced procedures whether, we can cross-share our own country's curriculum or something like that, or ABIP curriculum or ERS curriculum, something like that. What do you think? Do you think it's useful, or you think that it should be individualized?
I believe it shouldn't be individualized. I think it should be uniform. So description of the bronchoscopic finding. So the methodology, how to do bronchoscopy, flexible bronchoscopy, flexible inspection bronchoscopy terminology and description should be absolutely unified.
Yeah.
So we need some kind of international WABIP-based model, like a standard operative procedure in bronchoscopy, especially in description of the bronchoscopic findings. So we have to be sure that we are on the same page again, speaking with the same language.
Yeah, it's just like Scoptic, right? Where they describe the EBUS, so it's a kind of a standardized procedure so that, by having a checklist, we will not miss things so as to compromise care or something. What do you think?
I mean, gastroscopy, colonoscopy, they already have it.
Right,
I mean,
exactly.
we should learn from other endoscopic procedures. They have very well-developed system of description, even describing specific lesions in a certain standardized way. So what is the reason why we don't have it? I mean, we should have it.
Right.
So just a short comment about general endoscopy, because I also have a linkage in this area. So sometimes they're really doing this really complicated. For colonic lesions, you can find at least 10 different classifications from different teams in Japan, in Korea, in United States, and in Europe.
Yes.
You'll be completely lost in this. So we need to uniform and standardize thing.
Yeah. No common language, right? Yeah. Like even the yield, wasn't for the Blue Journal publication where they define the yield. It's not possible to even cross-compare studies to see whether, a new technology is really effective or useful for adoption, kind of thing. I think the biggest hurdle is really IP is kind of a niche subspecialty that we often cannot publish really good randomized controlled trials because every single patient is very different from the next one.
Yes, correct.
Okay, well, it's 9:52. I think my session time is up, so I'll hand it over back to Michael and Pyng. I appreciate everybody's participating and openly talking about your countries and your issues. I would love to see applications for IPI training, especially from Russia and all of your other countries too. So we take pride in teaching, training people from all countries, most definitely from developing countries. I know Russia is not a developing country, but if you have a need for IP, please send people to us. We will train and send them back to you. Please look for resources. If you have any donors, if you have any instruments you want to donate or money, even if you have somebody who wants to donate $1,000, that's great for our fellows. I didn't show you the list of our fellows who came from different countries, but our fellows are coming from Africa and East Africa, West Africa, South Africa, South America. Some of those countries have their annual salaries less than $5,000 a year, $6,000 a year. So for them to come to Turkey for 3 months and spend $4,000 or $5,000 and not get paid for 3 months is a huge expense. So we're trying to subsidize our education. Our book will be published very soon, and we will give it to all our fellows for free, hopefully next month. We will have a digital book, which we have put together on interventional pulmonology from all the experts from the world. And this book will be online for all our fellows, future, current, and past, for free as a resource for learning. Thank you very much. Have a great week. Have a great day. Bye.
Bye.
Thank you.
Take care.
I'm happy to
Bye.
report that we've had over 40 chairs and lecturers and about 500 unique attendees. So I thank you all for participating in a very monumental and important WABP webinar. Thank you, team, and see you. And these sessions will be replayed on YouTube. Stay tuned again. Thank you all.
Thank you,
Michael,
Michael.
Thank you, Michael. Great job, Michael. Thank you.
Michael and
Bye.
Pingley both did a great job of putting this together. Amazing job.
Thank you.